शान्ति भूमि तराई पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल बहु जाति भाषा धर्म संस्कृति छन् विशाल अग्रगामी राष्ट्र हाम्रो जय जय नेपाल।
Thank you, everyone. And now I want to carry this program as usual as our routine. So the technical difficulties sometimes here we have a light gun, so we on the line still. So according to our program, now I would like to ask Professor Peter Patel. He's the International Director of Disaster Medicine for the welcome speech, sir. So, yes,
Dr. Samir Adhikari, Chief HAOC, Minister of Health and Population of Government, Nepal. Professor Pradeep Vaidya, the Chairman of the newly set up Disaster Medicine Center in Nepal. Dr. Ramesh Maharjan, the Chief Coordinator, and of course, the founder of this program. First of all, I must congratulate you all on establishing this bold and innovative program, which is badly needed in the region. And of course, not to forget, I would like to welcome you all, our Nepalese colleagues, for actually taking this brave initiative and joining us on this special occasion. Welcome to Professor Virginia Murray, who is a truly international motivator and a leader who inspires doctors and healthcare professionals world over. Unfortunately today, Professor James Kingsland, Dr. David Bruce, and Jim O'Brien, they are unable to join us, but James Kingsland and David Bruce have actually sent recorded messages, and they also would like to welcome you and congratulate you. Rob Russell is one more person from UK Defence Team, an expert in disaster medicine, emergency medicine. And of course, I must not forget Jim O'Brien, former Director of Public Health, who is part of our international team, has worked in Tacloban, Philippines, hands-on during the period, and also not to forget Ebola crisis in West Africa. Today, we have a great team with us from our partners in India, who will be available at discussion time to tell us about their experience and journey of disaster medicine. Dr. Maharjan, I must say that you have put together a great Nepalese team of doctors for this innovative and, to the best of my knowledge, the first one in the world which intends to tackle the challenging areas of disaster medicine. I believe he will introduce his team later in this program. Most importantly, not to forget Dr. Santosh Pradhan, who is emergency medicine consultant, of course, of Nepalese origin, and it was his hard efforts with Dr. Maharjan that has given birth to this essential and very important program in Nepal. I do not intend to debate or promote the merits of managing disasters. Many people in government and health professionals even now believe disaster medicine is emergency medicine and paramedics, ambulance services. Unfortunately, they are wrong. Emergency medicine, paramedics is only a small part of disaster management. The concept of disaster medicine in most countries is absent. Disaster medicine is the most important part of disaster management in major, and what we find that in majority of the low and middle income countries, disaster leads to poverty because of mortalities and morbidities. It is our mission to build clinical capacity for disaster medicine in these countries with the aim of reducing dependency on international aid, reducing and improving health outcomes, leading to faster economic recovery and reducing poverty. Later on, I will present my journey into the world of disaster medicine. Thank you, Dr. Maharjan, Dr. Vaidya, Nepalese doctors, and welcome to you to this special launch program. Thank you.
Thank you, Professor Peter. Now I would like to welcome our chairman, Professor Pradeep Vaidya, for the welcome speech, sir. Nirajan sir, यता rhythm को on गरिदिनुस् न.
Okay, sir.
Rhythm को unmute गरिदिनुस्.
Okay, sir.
के अरे Dr. Rasmisha Maharjan उता प्रोफेसर वैद्य देखिराख्नु भएको क्यामेरा. उहाँले यो हेरिरहेको
Well, okay. Greetings from Nepal. Dr. Samir Adhikari, the Chief of Health Emergency and Disaster Risk Management, Ministry of Health and Population. Professor Peter, I hope you remember our long discussions long time back. Distinguished guests from abroad, and obviously Nepalese people, Nepalese distinguished guests. It's a history-making day today for disaster risk management. We've been working on disaster risk management for the last 15 years in Nepal and training people in other countries. And as Dr. Peter said, disaster risk management and emergency management and pre-hospital cares are completely different. We need to have a disaster medicine faculty so that we can train more people on disaster risk management instead of small emergency risk management, trauma management, or any other managements. Disaster encompasses a whole gamut, a comprehensive study of how to manage disasters. So today, I'm very, very happy and very proud that we are today establishing a disaster medicine in Nepal. And all the faculties, I like to congratulate you all for being faculties of this team so that we can do better training, better cooperation, better East-West, North-South trainings, discussions so that we can improve disaster risk management. Recently, we saw in Haiti again, there's a large earthquake, the climate changes, all make sure that we should be prepared. And especially in the countries like ours where resources are not as adequate as other countries, we need to coordinate and cooperate. For that, we need a lot of learnings. And we are so glad and so thankful to Dr. Peter and the team from abroad who are there to help us when this will happen and train people out there. So with the final words that today, thank you very much for attending this meeting. Thank you very much for establishing a ceremony, the disaster medicine in Nepal. And I'm very happy that we will continue this cooperation and we'll move on towards much risk-free, disaster risk-free, hopefully, management of people and saving lives on the way. Thank you very much.
Thank you, Professor Vaidya, Chairman, Nepal Disaster Medicine Faculty Board. So I would like to welcome our chief guest, Dr. Samir Adhikari, for your remarkable welcome speech in this establishment ceremony of disaster medicine in Nepal, on the disaster medicine in Nepal, learning from the world. Welcome you, sir. Okay.
Thank you, Dr. Excuse me, well. Yeah. Okay. Thank you. Thank you, Ramesh, sir. Respected Chief Coordinator of NADM Center, as well as the senior professors who are presenting here physically and virtually, and distinguished all ladies and gentlemen. Thank you for having me for this inaugural ceremony, and congratulations and best wishes for Nepal Disaster and Emergency Medicine Center. As all we are familiar that Nepal is disaster-prone country, and Nepal is one of the most disaster-prone country in the region, which encounters the range of geographical, hydrometeorological hazards such as earthquake, flood, landslide, lightning, fire, etc. According to the Global Report on Disaster Risk 2003, Nepal is ranked in most of the disasters. We can say we are in many prone areas, prone ranking. Fourth in the risk due to the climate change, 11th on the most risk due to the earthquake, 20th on the overall disaster risk, 13th on the terms of floods, landslides, as well as we are more vulnerable to the different diseases, epidemiological and road traffic accidents as well, which we have been frequently encountered. All these hazards compounded with multi-dimensional vulnerability and results in enormous damage to the infrastructure along with the health consequences. Not only the natural disasters, but also the man-made activities had been affecting us more. Consequent of these disasters, health is the one area which we have been facing lots of challenges. Health is among the fundamental rights that the government of Nepal has assured in the Constitution of Nepal. In Article 35 of the Constitution, we all are familiar that every citizen shall have the right to free basic health services from the state, and no one shall be deprived of emergency medicine service. The Disaster Risk Reduction and Management Act and the Public Health Service Act and regulations are the reflections of the Constitution's provisions. From these acts, we have different strong legal mechanism in the country to address the disaster management. The DrRamesh Act 2017 recognized both risk reduction and management as integral element of the dealing with disasters. It proposes a clear multi-tier disaster risk management institutional structure at the national, provincial, district, local, and the community level, as well as giving the clear directions for the establishment of disaster management funds at the all tier of governments. The DRM structure is divided into two main bodies. One is policy and administrative decision making, and another is the implementation bodies. In the policy and administrative structure, we can see that the Disaster Risk Reduction and Management National Council and the Executive Committee, two committees are there. And in the implementation roles, National Disaster Risk Reduction and Management Authority with the full legal status. Similarly, the disaster management committees at the different levels we do have. And similarly, the Public Health Act has provision for the emergency management from the health perspective as well. The National Emergency Operations Center was established in the country in 2010 with 11 different clusters to coordinate, communicate for the disaster information, access Nepal, including government agencies, and other response recovery with the different stakeholders. After the establishment of National Emergency Operations Center, Ministry of Health and Population realized that we must have to establish one health-related operations center in the central level. So in 2014, we established the National Health Emergency Operations Center, which leads the health, emergency nutrition, as well as WAS-related public health activities during pre-disaster, during disaster, or after disaster. Ministry of Health and Population identifies the importance of such important operations centers for the health sectors. And it established the high-level operational command center for disaster emergency management under the direct supervision of the Secretary of the Ministry of Health and Population. Consequently, later on, we expanded health emergency operations centers in all provinces. Recently, we do have 8 health emergency operations centers throughout the country, including the central one. These operation centers coordinating preparedness and response mechanisms and the existing emergency institutional mechanism for community, province, and the central level disaster risk management initiatives in the sector. Similarly, we do have the different network with the hub and satellite hospitals. Throughout the country, we do have 25 hub and satellite hospitals networks. A total of 25 hub satellite hospitals is coordinating with the satellite associate hospitals with their defined catchment area, which is a good example. Public is the good example for the public and private partnership for disaster preparedness as well. In terms of capacity building of the response to health emergency and disaster management, the Ministry of Health and Population has identified the 5 domains of training focused quality response in health emergency and disaster management in country. These are the planning and logistic, community care, pre-hospital care, hospital care, and post-hospital care. Ministry of Health and Population has been rolling out the training of different level of health workers, different domain of the emergency preparedness. As we can say, the emergency medical technicians and emergency medical dispatcher, ambulance driver, community-based first aid for pre-hospital response, facility-based hospital emergency care, emergency medical deployment team, and hospital disaster preparedness and risk management course for facility-based training, and step-down approach for the pre-hospital care interventions. Establishment, strengthening, and enhancing emergency medical services with priority of the government of Nepal. We are focusing on the 8 centrally controlled dispatch centers, basically dispatching ambulances, providing medical directions to the callers, functioning the culture of the information collection through app-based systems. These are also on our strengthening future strategy, future plans as well. Finally, I would like to congratulate the entire leadership team members and colleagues of the Nepal Disasters Emergency Medicine Center for these essential initiatives in Nepal. Responding to emergency disasters in a collective, collaborative work, and individual and stakeholders plays pivotal role in control and protect from the further possible harm. So Ministry of Health and Population look forward to result-oriented and collaborative actions and activities in the future.
Thank you very much, Dr. Samir Adhikari, Chief HUOC, Ministry of Health and Population, Government of Nepal. Now, our ceremony of establishment of disaster medicine in Nepal, the session 1 is concluding here. Before starting the session 2, the different presentation from our international speakers. So I would like to before we want to take one group photo. We want so that we can use the time. So we request for the group photo of the faculty, please. So I request for your time to be the this group photo. Thank you so much.
We can't hear, sir. Could you please unmute?
Establishment ceremony of disaster mediation. Now we are moving to session 2. I would like to welcome Professor Peter Patel, International Director, Disaster Medicine, for his presentation on overview of disaster medicine and overview of the journey in South Asia.
Okay, I think I have unmuted,
Yes.
and I hope everybody can hear me. I understand previously the sound wasn't very good, so could you please confirm you can hear me? Okay, thank you. I'm going to start sharing screen now. And okay, so this is about disaster medicine for India and Nepal. It's supposed to be a model for developing countries in future, the low middle income countries. And what I would like to say is that I have a founder partner, which is National Association of Primary Care, one of the largest association for GPs and primary care, who are our founder partners. Another one is Public Health England, and thanks to Virginia Murray, who enabled this development advisor partnership with for this program. Not to forget Crimidine, which is a Center for Emergency and Disaster Medicine, Novara, Italy, who actually run the European Master's course in disaster medicine. So these are our founder partners who actually enable this to happen. And I'm going to go through briefly our journey and our team. So very quickly, this is not our complete team, but these are some of the major team leaders. And not to forget Professor James Kingsland, who will actually send his message. International, they're all international experts and elite, some of the top, Professor Virginia Murray, who will be speaking later on. James O'Brien, I already mentioned. Rob Russell, defense medicine, another expert. David Bruce, pre-hospital care, Royal College of Surgeons, another one of the, he's the international chair for developing pre-hospital care internationally and an international course. Santosh Pradhan, he actually made this project happen, Annapurna Sen. And then coming to our Indian partners, we have the Sri Ramachandra Institute of Health and Education and Research. We have Professor P. Vijayaraghavan, the Vice Chancellor, and Professor Ramakrishnan, who had the vision 6 years ago to say, this is something we need, and without any major mistake, you must make this happen, and I must thank them. Tausif Thangalwadi, another expert, one of the founder members, and then we have Amrita Institute of Medical Science in Kochi, Professor Vishal Marwa, Sabrish Nair, and behind them there's a big team out there whose names I haven't got, but these are the actually visionary leaders. Arundhati Pawar, she's from Pune, and she actually is leading down the west part of India, Nilesh Jagtap. But not to forget that a lot of people have forgotten that pharmacy sector, what's the role of pharmacy professionals in disasters? And for that, I must thank Professor Rajashri Chavan, Sagar Bhise, Ravindra Patel, who have been collaborating to actually get the pharmacy and the role of pharmacy in disaster medicine going forward. So this is the major setup. So here, coming to our vision, say both India and Nepal are prone to a wide range of natural disasters. I'm not going to say much about India, but 80% of Nepal's population is at risk of natural disasters. And then, in addition to natural disasters, the subcontinent actually has many challenges, from mass gatherings, epidemics and pandemics. These two, right now it's happening, and chemical industries. Number of people affected in India. India is actually top number 10 in the world and for people affected, and Nepal is number 20 in global ranking. As this has already been mentioned by our previous speaker, Samir Adhikari, Nepal ranked 20th most multi-hazard country, 4th in climate change, 11th in earthquakes, 30th in flood risks. And then very quickly, which you already know, landslides, fire, drought, epidemic, storm, hailstorms, thunderbolt, cloudburst, avalanches, glacial lake outburst floods, GLOF. Okay, this is actually part of the sort of the view of the disasters which Nepal is facing. They lose 300 lives per year due to water-induced disasters. These are some old figures, 1971 to 2000, 50,000 injured and 27,000 deaths. What is the economic cost of this? Is huge. The Nepal GDP is about $1.4 billion US. 2015 earthquake, actually Nepal had a loss, 35% GDP loss, which was an estimate. Some of them estimate between 5 to 50%. But what this really means is that disasters lead to poverty. And that is something what we can do about. So my background to this started back as a Rotarian in 1993, some time back, okay? Some of you probably were not even born at that time. And it was Latur earthquake. And I was asked by people here, you are of Indian origin, what are you going to do about it? You know what my answer was? Nothing. And I said, we raise money here, we send it to these countries, but we really do not know what happens to the money. It goes into Chief Minister's Fund, Prime Minister's Fund, but there is no end result, there's no accountability. So don't send money there, okay? And this, I was told, saying, your academics are negative. Why can't you actually come up with some solutions? So what we said is, out here, we are not emergency medical services, but what happens to these people is that displaced people, they actually live in shanty towns and refugee camps anywhere between 6 months to 3 years. And there is no healthcare, nothing about them, they're just forgotten. So we started by building the first healthcare center in Latur, in Pomadivijavalgaon, and handed it back to the people. And that healthcare center, even now, is providing services to something like 25 villages. Yes, we had challenges. Because of the success of this came the Gujarat cyclone, Bangladesh flood, Orissa cyclone, Gujarat earthquake, and with high mortality and affected population. And all these projects were thrown back at me. So we continued to do same things, actually funding education and healthcare. But like anything else, we actually then look at, what does happen to this money? And our main purpose of us that is humanitarian purpose. And when we post Gujarat earthquake, we looked on return of our investment. And our core objective was to understand and manage healthcare impacts of disasters and find effective solutions to reduce adverse impacts of disasters in low and middle companies. So we looked at it, and part of the method was actually analysis of impacts and outcomes. We actually practically visit, I practically visit with a team to affected areas. We discuss it with community groups and interview them. We analyze the healthcare infrastructure resource and responses there. Some of those photographs, practically every photograph you'll see down here are personally taken by me during those visits. And what we found is that, again, there's a community focus group in Gujarat. This is actually the middle one over there is the temporary accommodation in Sri Lanka after tsunami, rebuilding of community health center, and bottom right is again post-disasters. These are children living in corrugated iron sheet condition 4 to 5 months after tsunami. So this is what happens out there. Now, understanding the economics, this is just as if from 1993 to 2011, we have actually done 18 of the 24 major areas have been visited, and we worked in these areas actually in hands-on work. So when we did the review, what we really found in the region that it had become a dependency syndrome. There was zero concept of disaster management, zero planning of disasters, zero preparedness for disasters, no paramedics, no pre-hospital emergency care, no emergency medicine, no trauma team building. So what we started was training of trainers, pre-hospital emergency care, disaster preparedness and ready programs. They started in 2002. And we did that analysis again in 2005, and there was an absence of concept disaster management and medicine. There was still an absence of trained paramedics fit for purpose. The ambulance service not fit for purpose. Okay, there was absence of emergency medicine, absence of trauma team building, limited management and control of epidemics and pandemics. And unfortunately, it's not only in these countries. If you have seen them COVID-19, in fact, every country has challenges for their plans for managing pandemics. Absence of disaster risk reduction mitigation. So what we started with, that we started consultation with these government agencies, and they assured us that the above aspects were being dealt by respective governments. Well, India had NDMA, National Disaster Management Authority. Sri Lanka has got DMC. Bangladesh has got its own Disaster Management Relief Division. And Nepal, not only in the 1982 Act, but you have moved significantly forward on that. So we partly stopped our investment there and said the governments are doing this. But once again, when we do a review, there was no progress made by government or agencies, NGOs, or training institutes on disaster medicine. Their disaster medicine was actually emergency medicine, paramedics, search and rescue, but beyond that, there was no capacity building for disaster medicine. It was a silo approach to working. There were limited resources to healthcare systems and absence of dedicated training for healthcare professionals. And that I can very clearly say that we did a survey and talked to something like 15 medical institutes down in India. And they said, well, what are you talking about? What's disaster medicine? And that actually made us actually move forward. So between 2002 and 2007, we started the program training the trainers. And actually Pune and Goa, we had Ruby Hall Clinic in Pune and Goa Medical College with the Goa state government were there. And our first program was actually supported by University Hospital Birmingham and Defense Medicine UK. The Royal College of Surgeons, they had immediate medical care, and they had a pre-hospital care emergency program there, and West Midlands Ambulance Services. The West Midlands Ambulance Services set up the first certifiable course for paramedics in Pune, which has now actually trained over 14,000 plus paramedics out there. Okay, this is the pre-hospital emergency care course of the Royal College of Surgeons of Edinburgh. And here in the middle, you may not be able to see it, but there is, we have Brigadier, there is Keith Porter, and then Tim Hodgetts, Brigadier, he was Queen's physician and expert in this, and the Goa team. Over 5 days, they were trained on the course, examined, and the pass rate was the same as UK. So this actually established that we can actually train them and train the trainers, and they can actually gain the necessary expertise. So in 2011, we revised our aim, and the aim was to establish disaster medicine of South Asia, India and Nepal as a model, mission, building clinical capacity for disaster medicine. Okay, the faculty will actually have a center of excellence in disaster medicine in partnership with the regional healthcare providers, voluntary groups, industries, and statutory bodies. Okay, so 2015, this was our team. And on the left-hand side, actually my left, so over there, you'll see two Nepalese doctors, Dr. K.K. Rai, Krishna Rai, and Pradeep Vaidya, along with our international team in the middle. Jim O'Brien is there, Luca Ragazzoni is there, Professor Kingsland, and some of the Indian experts. These were the inspiring leadership which actually started the faculty, which was launched from Pune in 2015. Okay. And these were the whole, that's the faculty, the first group of trainers, which actually we started training them, and it was a 3-day program over there. But what else do we do? And I'm not going to go through the long story. Actually, we actually go and study the potential risks. And I know if any of you have gone to Puri. This is Puri Rath Yatra. And we've been there twice. This is a very high risk area, but we are in the middle of it, studying this and actually saying, if there was a disaster here, how can we cope with it? So it's actually planning, preparedness, and actually an understanding response team. And down there, the great cooperation of the government with some of my doctors out there. But bottom right is a photo of their district general hospital, which was their capacity for managing any disasters. Okay, and of course, my visit post-earthquake to Nepal, and Krishna Rai, and we have a lady there from Jammu and Kashmir who joined us, and Jai Ganesh, who is an emergency medicine consultant, who introduced me to Santosh some time back. And we actually came there, studied it, and offered our help to actually what we can do. And this is again about June, July 2015. We actually were looking at, what can we do about this? Top right-hand corner, at that time, something like 2,000 to 3,000 people were living there in Kathmandu, right next to the hotel where it was open ground. This were the conditions, bottom right in tribe, were the sanitary conditions for there. And then if you look at the people living here, young people, babies, very old people down on the left. Now, and in this place, a doctor only came there for 1 hour in the morning. After that, there was no healthcare support for them at all. So this is what we say is that if you study the disasters personally, you're able to understand the healthcare needs of the people. And it's not something very simple. Disasters can be complex. Many of the disasters with rapid floods, earthquakes, and then they become, quite complex, including chemical fires. So I'm not going to go more into the details of this. That's part of the course, but this is what we do. So what do we do? International partners, which I've already mentioned. And with them, we have already actually done 8 pilot training sessions on the modules I'm going to say a bit later, 3 on COVID-19. In January 2020, before even things went worse, I actually came to India and said, here is a pandemic potential coming, and explain to them about, at that time, it was Chinese coronavirus or novel corona, not COVID-19 or not SARS-CoV-2. Including all this, training. There's one photograph there, which is actually PPE, the second one on the left, and trained people out there, but people were not interested. Actually, out of something like 10 organizations, only 3 of them took up the training, Pune and 2 in Chennai, which was with the help of DrRamesh and the university. So, and then of course, the other 2 photographs, which are our recent support to Nepal with PPE. But what I'm saying is we just don't do training. Where it's necessary, if aid's required, then our organization, we are able to, whatever limitations we have, but we will provide support of PPE equipment. Kochi has got pumps, syringes, and various other things. We are working with Chennai on actually providing with ventilators. So we do provide support to our faculty and our partners as necessary. This is what my house looks like. One of my living room is full of these boxes. There's no furniture there. And in the middle of the lockdown, nobody could come to us and nobody could go anywhere. So it was only me and my son getting all these material together, sorting them out, packing them, ready for dispatch. So these are, one has to take on the challenges and not say, we cannot do it. It's not possible. Everything is possible. Over 51 major packages were dispatched to Nepal and India during the period of this lockdown. So coming to this, our Indian University partner, Sri Ramachandra Institute of Higher Education Research, Amrita I mentioned, and our college partners, pharmacy. They're really the main innovators. United States does have a role for pharmacy in disasters, and there are few other European countries they have it, but majority of them, they think of pharmacy, okay, we'll talk to them about supply of drugs or doing this, but they never get involved in developing the pharmacy role in disasters. Okay, now coming to some of the leading, the work, actually this is a small list of the partners of hospitals which joined us in training. On the left, you'll see photographs of different, one in Delhi, other one in Chennai. That's the Kashmir. And the funny thing about the third photograph on the left, if you may not, you might be able to see it clearly, is this is in middle of Ramadan. This just before we came to Nepal earthquake. These are the doctors who in middle of the Nepal and they have to come hot climate, they have to come out to train first actually training program in disaster medicine. And of course the various launches and the trainings happening. So what does it really mean? Eventually, we looked at international courses of disaster medicine. There was 1 in USA, 4 in UK, Europe, the Belgium, Italy, which I mentioned, European Master in Disaster Medicine. There's a new one in University of Exeter, and there's a one in UCLan. And there is one which is the Society of Adhikaris. They do a course in conflict and disaster, catastrophe medicine. These courses, except for Society of Adhikaris, cost anywhere between these are postgraduate courses, $8,000 to $16,000. They are unaffordable. For developing countries, there will not be many people who will actually go to these courses, and when they go back, who's going to employ them? So our vision is to say, based on that reviews, that we actually developed a course, which is 16 modules, fit for purpose, and it actually takes in consideration resources of low and middle countries. The idea is to train the trainers and transfer the capabilities of running the course to the host institution. Okay, we are not here into building our empire. This is to say, here it is, we'll train your trainers, we'll give you all the support, and it's absolutely free of charge. We do not charge. We have right now invested something like £75,000 developing course and actually sending teams across over the period of 2005 to now. Unfortunately, COVID-19 has stopped face-to-face doing that. And what we are saying that the courses should be affordable, and it actually should include different levels to build capacity. Okay, so this is what we are working on. And right now, because of COVID-19, we actually transferring a course to online learning. A majority of the theory part of it, or what we call case-based learning, can be done by online. Okay, so what happens here is actually, these are the modules, and I'm not going to go into detailed modules. The ones in the red, which have already been tested and piloted out in India, and they do work with the objectives to test that. Okay, so this is, again, I'm not going to go into details. These have not been tested. The others do not need to be piloted, but they're all being developed right now. So what is a teaching and learning method? It's not didactic, it's interactive. It is situation problem-based learning. So we take real cases of disasters around the world and actually study that and actually try and find solutions, which will be preparedness, response, recovery. That's part of disaster medicine team building. Group learning, okay? We put people into groups, diverse and mixed teams, okay? So they're not all doctors or all nurses or all paramedics, mixed, okay? We are building distance learning right now, and the purpose is capacity building. Now, the course can be actually taken as, in a different way. It's level 1, which is continuous medical education and certificate. They can take 3 to 4 modules. So pre-hospital emergency care and related thing, 3 to 4 modules there, and assessment, and they get a certificate. Level 2 is slightly more advanced. It has got, you have to take 6 modules, but there are modules 1, 5, 6. The foundation course is actually on disaster management. And what we are saying is that you cannot do disaster medicine if you do not understand disasters. So anatomy and physiology of disasters is important. So they do a foundation course and then go into additional courses. So emergency medicine people will pick courses which are relevant to them. Some emergency medicine doctors actually do infectious diseases course, pandemics and epidemics and public health maybe, and CBRN, chemical, biological, radiological, nuclear disasters. So depending on what they want to do. And also we are looking at advanced diploma level, okay? And for that you have to do all 16 modules. But that is the one where you become the top team leader to understand how to build disaster medicine teams, how to actually be, prepare for disaster, medicine, disaster management and resources, and how to actually build the response and recovery. In a lot of the current disasters, the response and recovery is that short period between 3 days to 1 or 2 weeks or 1 month, but that's it. As I said before, in many disasters, the recovery could be anywhere between 3 months, 6 months, and those who are left, what you call displaced people, refugees, mobile refugees, they could be anywhere between 2 to 3, 4 years. And that healthcare comes as part of catastrophe medicine, disaster medicine. Okay, so with that, I'm going to, that's my overview. My congratulations to the Nepal team. All these very, very brave people who have taken this on board. They have a vision, and I would like to congratulate them and welcome them to our partnership. Very quickly, these are the people I already mentioned. These are our international experts, but there are many more than this who are a part of our team. Not to forget the people who have helped us in the past: West Midlands Ambulance Service, West Midlands Fire Services, Royal Life Saving Society, University of Pradhan, Royal College of Surgeons, Public Health England, Basics, NAPC, UK, and 25 more trainers. Okay. And our Indian team already mentioned, Professor Vijayaraghavan Ramakrishnan, Tausif Tangalwadi is another expert on hospital preparedness. Professor Vishal Marwa. I think Sabrish Nair is here with us today, and Sagar Bishi and Ravindra Patel are here with us today as well. So with that, in a nutshell, this is an overview of disaster medicine for India and Nepal, a model for developing countries. Welcome to the team. Thank you.
Thank you, Professor Peters. Now, I will play the recorded video of Professor James Kingsland. He's an international guest speaker. He is speaking on developing role of primary care physicians and allied staff in disaster medicine. So I will play, Niranjan, please make another, I'll go to that computer. The answer you Ramesh Maharjan देखेको छ अनम्युट पनि मेरो अनुहार देखेको चाहिँ यो मिलाउँदाखेरि अलि अप्ठ्यारो भयो Okay.
So I'm going to screen share also. I'll be the video screen share.
Hello and greetings from my home in West of England. My name is Professor James Kingsland and I lead the primary care of the Faculty of Disaster Medicine, which has been developing across India, and now delighted that we are engaging and becoming more active in the fall. I'm sorry I can't be live with you in the meeting, but I will be in Italy as this is being shown. But I'm so pleased that Peter Patel, who leads the overall faculty, has been able to develop to this point. I'm a primary care physician. I've been working in all sectors of the NHS in England for over 37 years, 31 of which have been in primary care general practice. But I've also been privileged to be able to work internationally and particularly with the Faculty of Disaster Medicine in India and Nepal. What I want to do in the 5 or so minutes that I've got with you online is to give a little bit of background around the importance of primary care within disaster management. Now, disaster medicine, of course, only entered the medical lexicon probably in World War II as a medical specialty until the 1980s. Now it's a complex discipline and unique in that we don't practice the scope of this discipline every day. Indeed, we never hope to have to practice this discipline, but we know how dangerous our world is, and we never totally sure what may be for us. We certainly weren't prepared for the recent pandemic. Even more so, it's only been relatively recent that primary care has really developed in the disaster management cycle and the importance that is placed on primary care. Now, I'm going to show just a few slides which just give a little bit more background to where primary care fits into the disaster management cycle. Whilst we often focus on the actual event and then the emergency response, which is so vital, we've seen in the early stages of our recent pandemic. Primary care fits is in the mitigation, the knowledge and prevention of disasters, being well prepared pre-impact. Of course, as we're seeing now, as we are hopefully getting to the tail end of the pandemic, I know it's still raging in certain parts of the world and across Southeast Asia, but as we go into recovery, we do know that primary care, particularly looking after the long-term condition,
Everybody, I do apology. That's because of the record system here. We couldn't listen the sound, so we will play that one when we have a time. So I would like to request Professor Virginia Murray, international guest speaker. She will speak on Sendai framework on disaster risk reduction and the role of healthcare developing sustainable partner. Ma'am, it's to you.
I'm unmuted. Thank you so much. That's really kind. And if I could share my screen, this would be lovely. Okay. I don't know if you can see my slides. Can somebody confirm it and that you can hear me, please? Can you hear me?
Yes, ma'am.
Oh,
Please
thank
go
you
on.
so much. You're really kind and you can see my slides. If somebody could confirm that, I'd be very grateful, sir. Peter, can you confirm you can see my slides?
Yeah, I can confirm. Can you hear me? Yes, we can see slides and hear you clearly.
Thank you so much, Peter. Well, first of all, can I say namaste? And what a huge privilege it is to be part of the group that is working for the Faculty of Disaster Medicine for India and Nepal as an international advisory board member. It is really special, and I thank you so much for inviting me to contribute to what I believe is a really vital and hopefully helpful initiative. Peter asked me to talk about the Sendai framework for disaster risk reduction, which I think, having listened already to Dr. Samir Adhikari, that you probably know a huge amount about and have been implementing, but also how we build, developing and develop sustainable partnerships. I have many roles, but my normal role is to be head of global disaster risk reduction in Public Health England, but I've also been for the last 18 months a senior public health advisor for Public Health England for COVID. There are many other things that I do, but I'll try and explain it as I go through. To me, the Sendai framework was an incredibly important UN landmark agreement. It was really the first time that we had this clear engagement for trying to understand what the impact of disasters are and how vital prevention is. As you know, the global outcome is about the substantial reduction of disaster risk and losses in lives, livelihoods and health. When we got health in that, I can't tell you how pleased we were when we were sitting, as I was representing science and technology at the time, and my colleagues were representing health, and we were really so pleased to see it in there. And in the economic, physical, social, cultural and environmental assets of persons, businesses, communities and countries. But most importantly, health resilience for a change at last is strongly promoted throughout. I know that you saw very briefly on James's presentation, the Sendai Framework for Disaster Risk Reduction's global outcome guiding principles, priorities for action, but also these incredible 7 global targets of reducing mortality, affected people, economic loss, and damage to critical infrastructure and disruption of basic services, particularly those that are health and educational related. And increasing our understanding of the risks of each country, both at a national and local country, strategies about disaster risk reduction through international cooperation and building on the availability and access to multi-hazard early warning systems and disaster risk information assessments to all the people by 2030. Jim, I know, mentioned the 4 priorities of understanding disaster risk, strengthening disaster risk governance, investing, enhancing disaster preparedness, but also at national and local levels, but also global and regional levels. Now, one of the most important paragraphs is the health paragraph, which I'm just going to take you through very briefly, which is to enhance the resilience of national health systems. And it's wonderful to hear some of the plans that are happening in Nepal at the moment. But it's developing the capacity of health workers in understanding disaster risk, complying and implementing disaster risk reduction approaches in health work. Peter, you summarized so many of the issues we've discussed before so eloquently. But the most important bit tucked inside this paragraph is promoting and enhancing the training capacities in the field of disaster medicine, this holistic approach about how we prepare, plan for, respond and recover from disasters, and obviously implementing the international health regulations. Now, I know in Nepal, you're very interested in the international health regulations, and having just looked you up on the WHO website, I see you're in the process of implementing it under a joint external evaluation, which is really exciting. But the 5 reasons why these recommendations matter is because, as with COVID, we know health threats have no borders. We certainly, in this time, we do not travel because of the risks of spreading disease. And global health security is increasingly important, and daily threats are kept under control, and that way all sectors should benefit. But what is so interesting is that although we have this incredibly powerful and legally binding international health regulations to the ministries of health, to the World Health Organization, what we don't have is this wider implementation of the Sendai framework routinely. So if you map the international health regulations, it comes out very clearly as this bubble of knowledge and things that have to be done from laboratories and surveillance systems, but it doesn't necessarily take us to this wider domain, which the WHO Health Emergency and Disaster Risk Management Framework now takes us to. So the disaster risk management framework is really changing the paradigm from an event-based, reactive, single hazard, hazard-focused, single agency, separate responsibility, response-focused planning for communities, to a risk-based, proactive, all-hazard, vulnerability and capacity focused, whole of society, multi-sectoral, shared responsibility of health systems, risk management, and planning with communities. What I like about the framework is that it has this wonderful front cover, which, as you can probably see on it, little white lines, which really we described when we were looking at how to design this, when I was working very closely with WHO on this, that it was the scaffolding on which we hook so much of what we already do. But it brings the whole story together about what we mean about health, emergency, and disaster risk management framework. So it aligns global health security, disaster risk reduction, humanitarian reform, climate change, and the sustainable development agendas. It bridges health and multi-sectoral communities. In fact, it goes to the whole of government, the whole of society. This is what we're seeking, and it's derived from all the things that we already do, but making them join up and work together in a much more cohesive way. So it addresses policies and strategies, planning and coordination, human resources, financial resources, something that we know we need, information and knowledge management. And that's one of the things we can bring through this faculty of disaster medicine, things we can share. Risk communication. I know in Nepal you do amazing risk communication, particularly after the 2015 earthquake, but it's a huge problem always for all of us. Health infrastructure and logistics, health-related services, community capacities for health, emergency and disaster risk management, and most importantly, monitoring and evaluation, because if we don't monitor and evaluate, we don't know if it works. Now, a part of that is that we have a WHO thematic platform for health, emergency and disaster risk management research network. And I am currently have the great privilege of being one of the co-chairs with my good friend Emily Chan from the Chinese University of Hong Kong. But the great advantage is that we link across all the WHO partners, from the headquarters to all the regional offices, including CRO, the Southeast Asia Regional Office. And from that, we have been building resources on developing guidance on research methods for health, disaster risk management. And again, I've had the privilege of being one of the implementing partners with over 164 authors from 30 countries, from all the regional offices of WHO, and we've done incredible work. But I wanted to show you one small thing that I thought you would enjoy. We did a review, and one of our chapters is on disaster risk factors, hazards, exposure, and vulnerability. And you will know that the second author is Ahmad Manit Dixie, who I've worked with for many years, who brought together much of the National Society for Earthquake Technology in Kathmandu. And we've produced this example of how we can look at structural risks during a hazard, using some of the incredible work that you've had to do in Nepal and the training programs you've already set up. So using that as a model, we feel this would be an incredible way to take the faculty of disaster medicine forward. The other thing we've published only late last year was the technical guidance notes on the Sendai framework for Ministry of Health, guiding the health sector by simplifying and standardizing reporting and providing information on key issues in the collection of health data. Why does it matter? Because we need to bring the Sendai framework, global targets and indicators to match the sustainable development, global targets and indicators, and make sure they all work together. Because we have to deliver what we know, because if we cannot manage, we cannot measure, we cannot manage. So the Sendai framework included this incredible statement about strengthening technical and scientific capacity to assess disaster risk, vulnerabilities, and exposure to all hazards. And this turned out to be a real issue because all the knowledge that we have, even from the open-ended intergovernmental expert working group, where the definitions of hazard and other things were accepted by the UN General Assembly in February 2017, we found that people struggled to understand it. So I've been tasked to be the chair of the technical working group to bring together the Sendai hazard definition and classification review together. What we found is that we have 8 major clusters of hazards. We have obviously the hydromet, and you have many of these, including the glacial lake outburst floods, but also extraterrestrial has come in. And of course, inevitably, very sadly, we have all the geohazards of earthquakes and volcanoes and other issues geologically, which, having no UN leadership, means that we rely on the scientists in particular. But increasingly, we've identified many of the environmental factors, including wildfires, but many other things that are really important to consider. And finally, we've managed to include here much more formally, which is so important for the health sector, are biological hazards. These biological hazards obviously apply to humans, but they also apply to plants, animals, aquaculture, insects, and other hazards. So these are part of our global hazard outcomes. We've included toxicological hazards. We've included technological hazards, including chemical releases, transport accidents. I heard that road traffic accidents are something you're really concerned about. And with the huge WHO commitment at the moment to the 10-year program, we would so love you to use the hazard resources we have. But we've also, although not in the Sendai framework, included for completeness the societal hazards of everything from civil unrest to financial shock. So here is the list of the 302 hazards that exist, and these will be published shortly as hazard information profiles. And the whole purpose of this is by bringing together the Sendai framework, the Sustainable Development Goals, and the Paris Agreement. This system of hazard definitions will provide a common set for monitoring and reviewing implementation that calls for a data revolution, rigorous accountability mechanisms, and renewed global partnerships. Now, the Sendai framework also talks about pandemics and epidemics. COVID, a real shock to us all, a real problem globally, and of great concern. So we have been very worried about the whole of the system of health, but also the whole of our community impacts. We know that it goes all the way from treatment to personal protective equipment, as Peter suggested, and all the supplies that were needed, and the training in infection prevention and control, to the incredible work of the genomics analysis, vaccines, and indeed some of the travel issues that we've been talking about, making sure that supplies are shared. As WHO says, it's been a year without precedent. A huge, massive task that all of us globally have been involved in. So the data from yesterday from the WHO dashboard, I thought would be helpful to share. We knew last night that there have been over 200 million confirmed cases of COVID-19, where these have been identified and reported. It's included over 4.5 million deaths as of yesterday. But there is one small piece of good news. As of the 1st of September, over 5 billion vaccine doses have been administered, although I know there's a great deal of concern for countries who do not have some of the resources that the UK has been using to develop the vaccines and share them. So I thought it'd be useful to look at Nepal. And we do know that although you have your population of about 26 million, you've already received by the end of August a total of very nearly 10 million vaccine doses that have been administered. So we know that you are still looking to try and improve this. But we also know that you've had at least 750,000 confirmed cases and over 10,000 deaths. So what a horrible disease it's been for all of us, and how worrying and how continuing it will be. So just to mention, under our hazard information profiles, COVID-19 is the only hazard that we're calling draft, because we're still learning about this disease. So in summary, I've tried to share with you a little bit on the Sendai framework, but I feel in Nepal, you have been very much a strong voice in its development, as I met your Nepalese colleagues when I was there for the negotiations, but also you are very much at the heart of its implementation. I know that you're interested in the Paris Agreement. I heard that being spoken about just now, and of course the Sustainable Development Goals. I've shared with you some reflections on the international health regulations and how we can take these into something even stronger with the WHO Health Emergency and Disaster Risk Management Framework to bring in the whole of government and the whole of society, which I think is the approach that you're beginning to use in Nepal, which is wonderful to hear. We have some guidance on research methods, and you're so delighted that Nepal colleagues have already been involved, but we'd love you to be involved again in doing more with us. And we've been providing, sharing the guidance on how we can try and build a system by which we can report to the Sendai framework the health parts of the impact of all our disasters and other hazards that could be used to help to measure so that we can manage better. We have the hazard classification that will come out that will actually define what we need to manage. And then in road traffic accidents, I think you'll like the hazard information profile on that very clearly. The definitions are, to me, a delight for the UN Statistical Commission that we've been working with, along with many other partners. But of course, COVID is there. We can't forget it. But let's look a little bit to the future. And maybe with the climate change conference that's going to happen in Glasgow, in company with our Italian colleagues, maybe we'll get a bit more traction to understand these terrible risks from climate change. And I look forward so much to being a continuing member of the faculty and trying to assist in some of the plans for further training and how we can help you to take forward some of this holistic views that you have on making sure that you feel that you're all a little more prepared, as we all need to be in disaster medicine. Many thanks.
Thank you so much, ma'am. It's a great message that we all learn from you to the world, and especially for the Nepal. Thank you once again. Thank you so much, ma'am.
It's a privilege to work with you. Anyway, thank you so much.
Yes, and welcome to Nepal, ma'am, whenever you are coming. Thank you. Now, with further delay, I would like to request Dr. Santosh Pradhan, member of International Advisory Board of Disaster Medicine. He is going to present on the role of emergency physicians in disaster. Dr. Santosh from UK, please.
Namaste and good afternoon. Let me share my screen. I hope you can see my screen share.
Yes, Santosh, go on, please.
Okay, welcome to this inauguration of disaster medicine in Nepal. Let me briefly go a little bit of background of myself. I am one of the Nepalese graduate. I trained as a health assistant and then went on to join MBBS 16 batch. I did the A&E residency job in Pradhan Hospital, United Nations to Nepal for 2 years. Then I came to UK, joined the emergency medicine rotation in the KSS and the Southwest London training. I did my membership and fellowship exam in 2012. And during the course of our day-to-day job, one of my consultant colleague, Dr. DrRamesh, he introduced me to Professor Peter, and at that time he was developing disaster medicine program training in India and Nepal region. Coincidentally, at the same time, Dr. Ramesh was also organizing a Nepal Emergency Medicine International Conference in 2015. I attended that, and I can very much vividly remember Professor Pradeep Vaidya giving a talk on disaster preparedness. And one of his, I still remember his favorite quote when he mentioned about Nepal's earthquake, the risk of it. It was not a matter of if, it is a matter of when it happens. And not to mention, it did struck in 6 days' time, and there were many aftershocks, and it was a true test of disaster preparedness and management. So during that time, our planning to implement disaster medicine training in the part of Nepal got a bit stalled. And there were other small disasters which did not took much of a international attention, but there were many landslides, flooding. And then, yes, in 2020, we have COVID-19. And then we have a second version of COVID in 2021, which has a completely different set of challenges, including medical management to the resource management. Let's go quite briefly to the disaster itself. A simple definition is a sudden accident or natural catastrophe and causes of great damage to loss of life. It could be natural or it could be man-made. Natural could be simple things like earthquake or volcanoes, and man-made could be armed forces or use of different explosive equipments or use of different electrical or other devices. It could be simple or compound. Simple basically meaning the basic infrastructure is maintained, whereas in compound, your infrastructure can be damaged. So simple things like electricity and telecommunication, bridges, road can be damaged, where the access to help in the disaster situation is compromised. The topic that I'm talking about is the emergency physician role of that in disaster. Like Peter mentioned, that the assumption of emergency physicians being the only disaster management is a flawed concept. And we will discuss why it is so. Emergency department is usually taken as a door to the hospital because it is the easy access, and especially for the unselected group, unscheduled care, and undifferentiated group. We do deal with daily emergencies of trauma, acute illness, and that is where we have a little bit of experience on prioritization of resources to the sick and time-critical cases. Now, when I say resources, we do have a limited amount of resources. Even in developed countries, our resources are fixed. And we have to decide on a day-to-day basis how we manage that resources and take calculated risk. So typical example is if you have 2 cases where you have a trauma and a stroke, which one will you send to CT scan first? Those kind of, from that kind of a simple managerial decision to a complex medical management decision, like which patient you will send to theaters or which patient you will wait and watch. And because of that, there is a general expectation to manage for emergency patients for a low frequency and high acuity events. So low frequency meaning one which occurs not on a daily event. So it may be happening once every 6 months, once every year, or once every couple of years. So simple things like car crash, multiple vehicle car crashes, fire, and lately the earthquake and the COVID. Now, just to give you a flavor of emergency medicine, a daily menu. So we normally see acute illnesses, simple things from rashes to very complex like cardiac arrest, meningitis, and acute and chronic like flare-up of Crohn's disease, those kind of stuff. There is trauma and accidents, which is mainly road traffic, falls because of conflicts and firearm and blasts. There is a category of undifferentiated patients where they simply present with very unknown symptoms like collapse, headache, unwell. And there are differentiated cases where they have symptoms getting worse. So cases like renal failure patients getting worsening of their symptoms. And there is a group of patients who we term it as unscheduled care, where it is because of the access to their usual services not there at the time when they need it, or because of the choice of the patient, they decide to come to the emergency department. Obviously, there are different, we see poisoning and different toxidomes, drowning, hypothermia, acute psychiatric presentations, self-harms. The reason for giving all the list of this A&E daily menu is in cases of disasters, this is the menu that you will be seeing in a very large scale. One thing to note is every day in A&E is different. No 2 days are similar. Now coming back to our focus on the topic, what is the similar, why emergency patients are linked to disaster management? One thing we need to be very clear is not only the emergency patient are responsible for disaster management. Emergency patient or emergency care is one part of it. There are multifaceted to it. But the reason for some similarities is the A&E team have a daily engagement with the multi-specialty, multidisciplinary, and multisectorial. Okay, so multi-specialty is like we daily deal with surgeons, medicals, theater staff, ITU. Multidisciplinary, we engage with physiotherapists, community nurses, pharmacists, and multisectorial. We do involve police. We do involve out of hospital kind of transport managers to get things in and out of hospital. And we do go with a comprehensive approach. This is happening on a daily basis, and this has some help in part of disaster management. And like I mentioned before, there is a daily, we are faced with a daily challenge of risk mitigation, because our risk is unlimited and our resource is fixed. So we have to juggle on a daily basis how we utilize that risk and take a calculated risk. One thing about emergency medicine or the emergency department is the only predictable thing in emergency is it is unpredictable. So that also goes in line with the disaster. The disaster can be unpredictable at every event. The volume of patient with acute presentation is different in everyday care. And then one thing of note is in our RChem training curriculum, major incident management, which is a very small part of disaster medicine or management, is there in our RChem curriculum. I've just quoted the curriculum code for it. It is freely available on the RChem website. So briefly touching base on major incident, which is a very small part of disaster medicine and management. So major incident itself is an incident which requires an extraordinary response by emergency services. Here, the emergency services does not mean only health services. So there are fire services, pre-hospital services, transport services, and sometimes security. So in cases of health services, major incident can be defined as an incident where the location, number, and severity and type of a live casualty, and I have to stress this, live casualty requires extraordinary resources. Now, for example, if there is a huge fire in a building and all the victims are dead, it is not a major incident for health services. It may be a major incident for a fire department. It may be a major incident for a mortuary. And it may be a major incident for police services, but it may not be a major incident because all the victims are dead. Again, major incident can be simple or compound based on the infrastructure, whether it was damaged or not. The photograph on the background, it was a major incident in one of the hospitals where there was a fire in the hospital. So the whole section of that building has to be evacuated, and the patients were treated in the car parking area. And let me just give you a small flavor of the compensated and uncompensated major incident. So compensated means when we input our extraordinary or additional resources, we are able to contain that incident. The uncompensated means even with all our extra effort, extra resources, the incident cannot be compensated. And disaster is always an uncompensated major incident. That is why it has a double star mark. Now, on the final bit, we talk about major incident training, and it is not only limited to emergency medicine. These are the documents which is freely available on the internet. You can download it. One thing about major incident training is that there are two parts of it. One is the knowledge and practice training. So you can acquire that knowledge by reading, going to the courses. And the second bit is the exercise bit, where you either do a demo exercise or what we call a drill in your institution, or you practice the knowledge, the things you have learned during reading all these materials into a real major incident. The major incident itself has taken some part of disaster management principles, mainly the mitigation, preparedness, planning, response, recovery, and finally, again, risk management for the future. For the frontline workers for emergency efficient, most of this will be looking at happening at the level of preparedness and response, whereas most of the work of recovery, risk management, and mitigation will be happening behind the scene. And of course, there is the major incident management training for the disaster management, only a small part of it. One difference between emergency efficient and the disaster management is there is a paradigm shift. This is what we call all for one approach going to one for all. Here in emergency department or emergency medicine or in hospital medicine, you have one patient which is being taken care at any single time by 4 or 5 different specialties, 4 or 5 different personnel. Now, moving that paradigm in a disaster situation where you have to manage by one person taking care of 6 or 7 very seriously injured or seriously ill victims. Now coming back to the disaster itself, why disasters are so different? Despite all the preparedness and planning, there will be an initial disorder or lack of immediate availability of resources. And this is where we need to plan and mitigate the situations. There is always the variability of number and types of casualties, need of multidisciplinary team, multi-agency, multi-specialty. And there is a multiplicity of tasks. Whenever the disasters happens, we will be, every one of us will be working beyond our competence and comfort zone. We have seen that during the COVID, where a non-ITU trained staff has been looking after very sick intensive care category patients. There will be a loss or lack of infrastructure because of the disaster itself or because of poor planning. And the effects of health system and the community. And one of the things of disaster is that this is called a first wave and second wave. Whenever there is a first wave, the immediate victims arrive in the hospital or in the other health sector or other institution, where the second wave is more sick victims arrive, trickle down at a later stage, and we need to be planning and preparing for that. And finally, no two disasters are the same. We have seen COVID-19, how it affected in 2020, and how it emerged and affected and damaged our health memory in 2021. Now, this is a wake-up call for all of us that accepting that disaster will occur more frequently. Hence, there is a need for more training, preparation, and planning. I took Professor Pradeep Vaidya's quote, if we do not plan, when we will plan. Okay, so that will be all for me. Thank you very much.
Thank you, Santosh. Thank you so much, Dr. Santosh, for your such a great message that all the main emergency physicians, those who are working in every corner of the country, all over the world. This message is more important that you mentioned the wake-up call for everyone. Thank you, Dr. Santosh, for such a marvelous message spread all over Nepal and all over the world for the disaster medicine. Thank you so much, sir. So now I would like to welcome now Professor David Bruce that I think we have a technical problem at the moment here, so we couldn't play the recorded. So now I would like to welcome Dr. Nobindraj Vista, member of Nepal Disaster Medicine Faculty Board. He will propose on the formation of Nepal Disaster Research Group by the Nepal Disaster Medicine Faculty Board. So this is, we propose from Nepal to the International Disaster Medicine Board also. So Dr. Nobindra, would you like to go ahead, please? Okay. Yeah. Please.
Thank you so much. I'm Nobindraj Vista. By training, I'm anesthesiologist, working at Tribhuvan University Teaching Hospital, one of the tertiary hospitals in Kathmandu. Apart from my training, I'm interested in research, and we have been conducting few important research in COVID-19. Right, starting with April, I was one of the core researchers for preparedness of COVID-19 under government of Nepal, and one of the important research that's going on is phase 3 clinical trial on favipiravir, and we are very happy that this is the first clinical trial that is undergoing in Nepal in COVID-19. So in this background, now I would like to enter on our topic. So as you know, at present, the disaster in Nepal are occurring frequently and has created a continuous threat to Nepalese citizens. So there are many ways for its solution, and one of the ways to mitigate such notable disaster is by collecting and feeding a good scientific data to all stakeholders, right? So indeed, such data will help to generate the evidence in this era of evidence-based practice, and that will lead to help government, right? So it is possible through conducting a research in Nepal. And I would like to advocate that will be one of the reliable assets to support and act as a complementary partners in terms of supplementing scientific data to the government for the national planning. So beside providing data to the government, it helps to other stakeholders as well. So what those who are helpful for it. So there are scholars who are working in disaster. So it will be very easy to use those data. The second would be for all the researchers and students of disaster medicine, private and public disaster organizations, even the disaster victims, and the financial department of government of Nepal. Once we start doing a research or a study in disaster, it helps to provide such data for international level, and Nepal will be one of the core family members in the global arena. So the mutual relationship to different international organizations will be really benefit for Nepal. So in this context, what are the type of study we can do? I'm thinking about we can do two type of study, right? One is, if you divide in a broad category, we can go for pre-disaster study, and second could be a post-disaster study. In the pre-disaster, we can think about anything that helps for preparedness and prediction of the disaster, whereas in post-study, it helps to weigh the disaster impact. Impact could be in a different form, like, for example, we are not thinking about what will happen to the victims when they hospitalized, right? Who is going to take? We are taking the care of those hospitalized patients. What is the condition of mental status of all those victims? Financial constraint and the social impact to the family, and also in long-term support can be made through such data. So we can have some action plan to do such research. So if you could talk about Nepal as being a low one of the developing country and falls under low income country in the world. So we can start the study by like exploring the area of research that matches to Nepal. Okay, so we can generate some research questions first. Second, we can apply for ethical clearance from ethical review board, that is ERB, from Nepal Health Research Council, which is the governing body of research. And third, after conducting the research, we can properly disseminate the results and suggestions to this public and concerned authority. And finally, our most important move should be like we should give a continuous push to the government of Nepal and all stakeholders to develop programs to prepare and manage disaster in Nepal. So these are the way we can do it, right? So what are the prerequisites for this research? Firstly, we need a dedicated research team, both from Nepal and abroad. I don't think only doing a research within with the faculties within the nation will not be benefited in a large, but we can have a collaborative role from the international faculties as well. And finally, grants are very important, and we can apply for grants in national as well as international area. So on this background, I would like to put a proposal today to establish a disaster medicine research group, which we can term as DMRG, okay, under this Nepal disaster medicine course. And now I would like to request all faculties to give their input on it, so that academic and scientific best practice continues ahead with this program. With this note, I would like to thank you for giving me the opportunity and giving some thoughts to establish this research group. Thank you so much.
Thank you, Dr. Vista. And so this is what we would like to put in the floor of Nepal disaster medicine faculty board as well. And now we would like to welcome Professor David Bruce. He's a pre-hospital care faculty of Royal College of Surgeons, Edinburgh. And his message to us is the international course in pre-hospital care. And we have a recorded version of his message to us. So we would like to play that one. Kindly bear with us. Yeah, sir, actually your screen share or go.
हजुर कुन चाहिँ आइडीमा सर?
So with this time bearing, because this is always difficult sometimes with this virtual. So I would like to request Mr. Bimal Singh Bista for his remarks on today's ceremony as well as Nepal disaster medicine. He is the emergency intervention officer in WHO Nepal. Up to you, sir. Yes, sir. Yes. Would you like to?
Namaste. This is Bimal from WHO. And most of the things have been already covered by the Chief of HOC Ministry of Health and Population. And I just would like to congratulate the leaders and the professionals to continue this intervention of this initiative in Nepal. So this is a historical moment in Nepal, actually. So many things are to be done. and even evidence-based system has to be established in our country. So we're very happy to collaborate and to see some other, let's say, things to be covered in big picture. Thank you so much for inviting us in this flow. Thank you so much, Dr. Ramesh and all the team members. Thank you.
Thank you, Bimal, sir, for your remarks on this point. In fact, due to technical problem here with some of the light problem, we are couldn't play the message. Is that okay now? Okay, so I'm hand over to the next computer to play the record information. Please, screen share. Niranjan sir, actually you. Niranjan sir, yata. Yata marks po. Okay.
supports your endeavors in this important area.
Okay, now I would like to go with my brief presentation on the importance. Thank you for bearing some of the technical difficulties on the records. So now I would like to share my screen once again. So, slide show. Okay. Okay, once again, namaste to everyone. So I will go through the brief on the importance of disaster medicine in Nepal. So once again, welcome all our international guests, our dignitaries and participants from all over the world. So as our previous speakers has mentioned the importance of disaster medicine all over the world. So the thing is, Nepal is the country with the chances of the disaster every time, anytime, everywhere.
Excuse me, sir. Screen is not hearing, not seeing, sir.
Unmute मेरो actually मलाई पठाइदिनु होला मेरो साउन्ड सुनिराख्नु भएको छ
सुनिन्छ रमेश दाइ त्यो स्क्रिन शेयर चाहिँ तपाईको डेस्कटप मात्र भइरा छ हैन त्यही भएर तपाईले चाहिँ डेस्कटप क्लोज गरेर पावरपोइन्ट शेयर गर्नु ओके म यताबाट शेयर गर्छु साउन्ड सुनिराख्नु भएको छ है साउन्ड सुनिन्छ ओके ओके यो स्क्रिन शेयर भयो मैले यो स्लाइड शो ओके that मैले चाहिँ भन्छ स्लाइड शो गर्नु पर्छ यताको यो देखेकोले देखिरहेको छैन ओके म यता यता माथिबाट सरी फर Okay, I will go through this one. So the slideshow a little bit. Share bhayira chaina? Share bhayira cha. Tapai चाहिँ top right top left corner ma चाहिँ तपाईको slide show को तीनटा icon छ. If you can click that icon. Top left corner ma छ. Next to menu तपाईको त्यहाँ slide show भन्ने त्यहाँनिर हुन्छ. You slide show F5 कता No. Okay. Okay, thank you. Now, it is clear to my voice also? Slide. Yes, voice is clear. There is no slide, so. Just wait for me. त्यही अघिको पहिला खुब बन्द गर्नु यो यताबाट खोल्यो अब देखिराख्नु भएको छ Only your desktop is being shared. You have to share the PowerPoint presentation. Yeah, now it is shared.
Okay then. Okay. Sure, Bob. If you remove Noni.
Arrow key chalan bani.
Okay. Okay. Thank you so much for bearing with us. As Nepal, everybody knows the country with Mount Himalayas, then the big hills, then the Terai. From the north to south and east to west, and all the beautiful country, the small country in between the India and the China. So we are always prone to have this disaster. So disaster we saw and we know in Nepal during our life at the moment. Basically the first picture we see is the National Stadium disaster, where the people have been lost their lives during that disaster. And everybody remember the earthquake of 2015, and the flood is still with in our day-to-day life nowadays because of the heavy rains. And we have avalanche as well as the fire, and also of course we have the air crash. So these are all various type of disaster we have. Beyond of this also we have a lot of disasters we have. So we want to remember or recall the disaster in Nepal in our generation. That's why we have to preparedness for the coming generation also. The stadium, because the new generation, they are so much fun with lots of game. That's all happening in the stadium. But due to at the moment of the COVID disaster, we are not on that. But in the future, we have to plan and think of this type of disasters that we have to prepare for. And there are another one publication that we can see in the prevention web from why more women die in natural disasters. So these are some of the data has been given from those Mr. Nepani on the various study on the woman's life during disaster. So that is also the consideration we have to take, and we have to know that that's why it is important. And already Professor Peter Patel has mentioned on the disaster medicine for India and Nepal, or model developing countries, that he has already talked. And also the Dr. Santosh has mentioned a lot of things on the Nepal, why it is important, the disaster medicine in Nepal, as well as in other parts of the country. So for that we had been doing the work since 2007, when we from the Nepal Disaster and Emergency Medicine Center, with the aim of emergency medicine development, emergency nursing development, emergency paramedics development, and the disaster medicine. So these are still in our website, www.nadem.org.np, because we developed this as a present to the future for the emergency medicine. There are the 7 days of the work. So there are a lot of programs from all over the world. So that's why we still preserve these things in the website, so that everyone can get and make the lessons that what we need in our country. And for the Nepal, for the emergency medicine, emergency nursing, emergency paramedics, and disaster medicine. That was in 2015 April, 1 week before the earthquake happened. So that's the message still we have. That is what we are doing. And with this COVID emergency, also at the time, there are a lot of data that we can see from the emergency service at the moment in the various part of the country, as where I'm working in Tribhuvan University Teaching Hospital. We can see that some of the data is that important, and we can see the deaths and the broad death that comes before and after the COVID disaster. So these are also some of the day-to-day life emergency service, emergency needs, as well as the disaster as such happening in our life. So that is why we need. And thank you for the Dr. Samir Adhikari, who came and inaugurate this establishment ceremony of disaster medicine in Nepal. And so we must thank you, Government of Nepal, Ministry of Health and Population, and also the WHO Nepal for publication of the report on Health Emergency Operation Central Network of Nepal, the Boys and the Vista of 2021. This is the recent report that we can see in the website as well as on the various media for this report. And in 2011 also, there was a Nepal disaster report that we can Google it and see the lots of the disaster that happened in our country. So with that, the Ministry of Health, HUOC, along with the WHO, has really made this message of Nepal earthquake 2015, flood and landslide still that is happening in our part of the country in different parts from the east to north, from the south to north, as well as the east to west, all the parts. So I don't want to go all the details on that. And for the various work that I am also involving in this mission of the government of Nepal for the contribution of what I learned from my career in the emergency medicine and the disaster medicine. So I must thank you, WHO, to have this initiation in Nepal to build the emergency healthcare system in our country. So that is one of the milestones that to take the right direction of this system in our country. Now that leads to also with the help of such a respective team of the various organizations and the Ministry of Health, specifically HUOC, to guide us, as well as we are in your mainstream to develop this disaster medicine in Nepal for our people. So it is from all over the world that we are getting the support. And thank you once again to the international organization, international board team on the disaster medicine for your generous support to us. And thank you once again to everyone that our board of the disaster medicine in Nepal, learning from the world, Nepal Disaster Medicine Faculty Board 2021, who are all the teams and all the things that is with your support that we are doing at the moment. Therefore, we are here. Let's begin the journey to its destiny. That is what I want to say for this. And again, in conclusion, this health system, we have met the 5 P's like pre-plan, preparation, practical, priorities, problem solving, and prevention. So this is all the emergency health system as well as service with disaster medicine for us to develop further. Once again, thank you, the chief guest, international and national guest, international board member of disaster medicines from India, from Sri Lanka, and from UK and other various international countries, and Nepal Disaster Medicine Faculty Board members, international and national participants. Those are on our Zoom as well as the live from the Facebook. We have lots of the participants that we can see all over the world at the moment, and also the journalists, those who are supporting on this mission. Thank you. I have to mention Pratibha from the Nepal television for making the interview with us and the broadcasting from the Nepal television to our people in the country and also online for all over the world. And also the thank you to all the supporting organization, admin team, and everyone to save life. Let's live together. So with that, I want to thank you, everyone. Thank you. Now, I would like to go back to the session 3 program. So I do apologize, we couldn't play the recorded system. So with this, I would like to mention to conclude the session 2. Now, without further delay, because we are on time ahead, we want to take you to the session 3 panel discussion. So on that, I would like to invite our international speakers and international disaster medicine board members from the India, Sri Lanka to join to us in this panel discussion. So Professor Peter, with your permissions, may I go ahead?
Please do.
Yes, Professor Peter. So with your permission, sir, as you have correctly mentioned, the disaster medicine in the world, now in Nepal and in Asia, in India, Sri Lanka, Bangladesh, Pakistan, these are our neighbor countries. So would you like to explain a little bit again for some words, sir?
And which area would you, what I would like to do is invite questions from the panel. Any specific question?
Yeah, I think so. Our international board member faculties from the India and Sri Lanka, I do request them to join with this panel discussion also, sir.
Okay. I mean, while we are doing this discussion, I don't know whether I would like to sort of say the shared experiences of people I have worked with, we have worked with. So I don't know if Professor Rajeshri Chavan, can you hear me? And Sagar Vise, are you there? Please unmute. Rajeshri Chavan, can you hear me? Yep, can you unmute, please? Left-hand corner, unmute your. Same for Sagar. I think they need a technical help. Can you unmute these two?
Okay, sir. Actually, we were not able to talk because host has muted us. Okay, but now we can talk. Okay, yeah.
So I think we have now worked for over a year with you, and yes, trying to sort of look at the role of pharmacy. And perhaps you would like to tell us about your experience and the benefits it brings to the country, please.
Well, thank you so much for inviting us for this inaugural function of disaster medicine in Nepal project that you have venturing through. The role that pharmacists are playing in the disaster medicine has been though clearly has been defined by Peter Patel sir, and we are in a project wherein we are training the faculty actually for providing with some modules as Peter Patel sir has already discussed. So it is the project that we are going through is definitely going to contribute to mitigate the kind of disasters which we are going through, the way we are going through COVID-19, and maybe probably with different kinds of disasters which may come in future. So that way, pharmacists are going to definitely contribute in the resilience or mitigation of those disasters and the effects that we are getting afterwards due to these disasters.
Thank you very much. Sabrish Nair, are you there, Sabrish? Can you hear me? Sabrish Nair?
I request Niranjan, our IT team, could you please unmute everyone and they can do the mute and unmute, yes.
Okay, anybody, any questions?
So I can ask our Nepali board member also if you have any for some question to our international team, please.
Yeah.
So I can see here the Mr. Sagar, this is from India. Sir, would you like to explain a little bit your words on that? Sagar.
I think Sabrish Nair is here as well. Can you hear me, Sabrish? If you raise your hand. Yeah, can you unmute? Okay.
Okay,
so SBN needs to be unmuted. He's a emergency medicine consultant at Amrita, Kochi. And we have done quite a few sessions, actually had face-to-face sessions there. We've done 3 major sessions there. Can technical people unmute Sabrish, please? SBN on that screen. SBN. Technical, please. Can you unmute SBN? No.
SBN. I just wait, sir. I will try.
Is SBN, that is Dr. Sabrish Nair.
No, he's
unmuted. He's unmuted.
Yeah. Hello.
Welcome, sir.
Hi all. Thank you.
Yes.
Thank you, and congrats to the team from Nepal. Greetings from India. I'm from Amrita Institute of Medical Sciences from the state of Kerala. So it has been a pleasure listening to you all today, all the deliberations from the international speakers and your team. And good luck from our side, and looking forward to meet you in person after the pandemic. So the journey so far has been very interesting and enriching for us and our team. We had first met Dr. Peter Patel in 2018 as part of CME in another private hospital. And since then, we had signed an MOU from Amrita Institute with Saving Lives. And the first initiative was in 2018 when we had our Kerala floods. So Dr. Peter's team had visited the site in a town called Aluva in Kerala, and we had more of a damage assessment report was formed. And we also had closed-door interactions with the district health administration, and the report was discussed in detail. And also we had a consultation workshop during that time. So a lot of inputs were there from that session. Then in 2019, we had our the foundation course, the disaster medicine foundation course for trainers. So that again was very interesting because it was conducted in March of 2019, and we had some scenarios where the wearing of PPE and pandemic simulation scenarios were also discussed, which came in handy for our team during the early days of the pandemic. So a special thanks from our side for a kind of an overview during those days. So that sessions were taken by Dr. Patel himself and Dr. Jim O'Brien and Dr. James Kingsland OB. So and there was a lot of inputs and a lot of interactions from their team, and we have been keeping in touch even after that. And also the other thing was that we have made our curriculum development for disaster medicine, and the board meeting was also held during those days. And we are in the process of formulating the disaster medicine curriculum for our university. So that's the journey so far. And even with this COVID, there has been a lot of help and guidance from Dr. Patel and team, both in terms of like medical expertise and also with certain donations from their end. So that's the journey so far, and let us see how things turn out in the coming days. Once again, congrats for this effort and good luck.
Thank you.
Thank you.
To enable discussion, technical, please, can you unmute everybody so that we can have a discussion, because people are not able to actually talk to us because they've been muted by the host. So please unmute everybody.
Okay, so I would like to also welcome Mr. Chudamani Pandari, sir. Chudamani, sir, are you there? Chudamani Pandari, sir, are you there? I'm trying to unmute him. Yeah.
There is a hand raised by Dr. R.Y. Patel. Okay.
Okay, sir.
Okay, Dr. Bhandari is there. Yes, please. Dr. Bhandari, please.
Yes, Chudamani Bhandari, sir. He is the ex-director of HUOC, and he is just retired from the Ministry of Health for his 43 years of career. So he has a lot of experience on the disaster management as well as the disaster happening in Nepal. So would you like to mention some words, sir?
Thank you, Dr. Ramesh. Actually, I'm here to see all the things and hearing from the very beginning from professors and all the experts from different countries as well. So thank you so much for organizing this event and inviting me to participate. Actually, I don't have to say too much for today because this is just first orientation for me also, and there are so many things we can do together, working together. And this is a great initiation. Thank you very much.
Thank you so much, sir, for your wonderful words. Now, back to Professor Peter.
Okay, I think R.Y. Patel, are you unmuted now?
Yeah, I'm unmuted.
Okay, we can't hear you. Can you speak up into the microphone, please?
Yeah. Is it okay?
Yes, now it's okay.
Okay.
Welcome, R.Y. Patel, sir.
Yeah, thank you so much. Much.
Please go on, sir.
Okay. I first of all congratulate the Saving Lives for having the session as a disaster medicine in Nepal. And it's a great thing to have with you all. Actually, Dr. Patel sir had visited India and especially in Pune. And I had a good conversation and we had a MOU. Actually, I am working as a professor in one of the pharmacy college at Saswad. And we have prepared a MOU and at present we are having the sessions which are been going on to train the professors for the disaster medicine. And we had plans that we should train the professors and the same training would be given for the students, where many of the students, we will have a large group of students which can help us in different forms of disaster. So it's a great thing that we all are coming together for a noble cause, that is to help the disaster effective peoples. And so I once again congratulate Saving Lives, Dr. Peter Patel sir, and the Nepal people, or the Nepal, all the people who have been involved in this organizing Nepal Disaster Medicine Faculty Board. And I would rather think that we can have a very beautiful work for the Nobel cause. Thank you so much.
Okay, I meant to give you a little bit more clarity on Dr. Patel. Is after the March 2020 COVID-19, when all the travel stopped, we couldn't actually do face-to-face training. So this is for one group. We have been trying to actually and testing and piloting online training. So we have now had 8 Zoom online training with them. And there were 2 groups, train the trainers, professors.
Exactly.
And there was another group which was actually to do with mitigation planning for Pune. I don't know if people remember that Maharashtra had the single highest number of cases and deaths from COVID-19 in wave 2. So throughout this period, we've been constantly working with these people and actually trying to establish and also look at wave 3 mitigation planning to actually distributing face masks to very poor people slum areas and motivating them, leaflets to make them understand their language, the importance of appropriate COVID behavior. Mapping the healthcare facilities, where the who is doing what, how to actually reduce unnecessary CT scans and all those things. So that's just to put actually real online the drugs, not being available, but also inappropriate use of drugs in COVID-19. So we've done quite a lot of work there. And that's a pilot to say, is during these difficult times, how can we make online training work? So thank you, Dr. Patel, Dr. Chavan, and Sagar Vise, who have been instrumental in helping us to pilot these programs. Thank you.
Yeah, thank you, sir.
Okay.
Thank you, Professor.
Can we unmute the rest of the team, please? Everybody, there's about 28 people. Then unmute them so that they can speak.
Everybody is unmuted. Anybody can talk now.
Okay, thank you very much. So,
Peter, yes.
Yeah, people, if you just click your unmute, you'll be able to speak.
Or you can press your space bar and speak, yes.
Sagar sir, may I request you to put here some words, please?
Yes, sir. Actually, I was muted.
Welcome.
So technical issue was there. Okay, it was solved. So first of all, I congratulate for establishing a ceremony of your disaster medicine in Nepal. I'm here because of Dr. Peter Patel, sir. And we have started working from last 1 year. And we have found one thing here. Actually, Peter Patel, sir, his vision was there. He has found the huge vacancy or huge, we can say, potential is there in a pharma field. Because we have found there is no place for the pharmacy peoples. Okay, not exactly frontline worker. We are never, we can say, part of in a disaster. So it is his vision, and we are trying to, we can say, impart in his vision to give some efforts in a field of disaster medicine. So I am hoping I will give all my inputs in this particular course, as well as again I will congratulate for establishing a ceremony of disaster medicine in Nepal. Thank you.
Thank you so much. So I would like to request Lisa Whitehouse for a few words. Lisa, are you there? Yes, welcome.
Thank you very much. Namaste. Hello to everybody. I'm speaking from Southwest England, and it's an absolute pleasure and a delight to be with you all today for this inaugural ceremony. And thank you very much for inviting me. In my professional capacity, I am in private practice in England. So podiatry, biomechanics, orthopedics, but I also work in Nepal in terms of children's education, and also I sit on a national committee for an organisation called Brango, which is the Britain and Nepal NGO network, which encompasses all NGOs working under all the SDGs, and I chair, as well as sitting on the main committee, I chair the health working group for Brango. I'm also delighted and so proud to be an honorary member of the Nepal Doctors Association UK. And it's actually my great pleasure to have been with you all today and to listen to the presentations and to meet you all virtually. And I look forward very much one day when we can all meet in person. But I wish everyone the very best of luck. And I hope very much that I can be a part of the organisation and help in any which way I can. I'd be delighted. But thank you very much for having me.
Thank you, Lisa. Now I would like to request Aru Pawar for a few words. I'm right, Aru Pawar,
Yeah.
yes.
Yeah, hi, this is Dr. Arundhati Pawar.
Welcome.
I work, thank you. So firstly, let me start by congratulating you all, because it's a huge task to establish disaster medicine. The field of disaster medicine is not very well understood, and then to actually establish an entire team and set the ball rolling. So hats off to you guys, excellent work and all the best. I'm sure you will do very well. So I work with Dr. Patel from the western region of India, that's Maharashtra state. And I'm based in Pune, and I've been working with him for about 2 years. So we have done a couple of, as he rightly mentioned some time back, we did a lot of online programs for educating the doctors, because that's the only way we could do it in this pandemic, where we are not allowed to congregate. We're not allowed to meet each other. And I think it worked pretty well. So that's a module, I think, which we will be seeing more often in the future. And also the mask distribution project was quite effective in terms, because something which we take for granted, like a mask, which we feel it's not a big expenditure. But for those daily wage workers and those who are really below the poverty line, it was a big help for them when we gave them the masks. So yes, we did a couple of programs. And in fact, Dr. Patel was one of the first people to take the hands-on workshop just before the pandemic hit and the lockdown started. It was really very useful. So all the best to you guys, and I hope that we will be working together in the future.
Thank you so much. Thank you so much. Now I would like to again back to Santosh. Santosh, are you there?
Yes,
yeah.
Okay. Dr. Ramesh, are there any questions on the floor or from the chat box?
Due to some of the technical, there are one nurse. It is mentioning how should nurses be activated for disaster management? Should government be more sensitive to EMS from the government level in Nepal, as most of the people are under poverty line that they cannot afford the private EMS? So it's from Divish Kharka.
Peter, do you want to
answer that question?
Yeah.
Yeah. I think is Davis Karka, are you there?
Yeah. He is there, but he is muted. Okay.
Okay. Otherwise, he can directly ask the questions.
So Peter, do you want to address that question?
I was just going to say, Santosh, if you would like to.
Yeah, I mean, the issue with EMS in Nepal is it is not well-established EMS system as compared to the Western countries. So whatever we have got is more or less of an extension of hospital going out in the community. The proper EMS system is completely separate to the hospital services. Now, it is not that well established. And coming back to Deve's comment, that how do the people who are below the poverty line, how are they going to afford that? Because at the moment, whatever EMS system we have got, there is a cost attached to it. And this is more of not only accessibility, but also a part is affordability. Now, unless this part is endorsed by government, and it is more the whole workforce on EMS is expanded out of hospital, and it is made more affordable. I do not see this is not something which can be achieved within the scope of disaster medicine. This is more of a collaboration work with disaster medicine, with government, and probably some NGO and private parties. The training and practice sessions can be organized by disaster medicine faculty itself. However, the endorsement needs to come from the government and other private parties. Is that fair enough to ask Dr. Ramesh?
Yeah, now Devas Karka is there. Please go ahead. Devanshi Karka. You have raised the hand and please, you again on mute. Yes.
Hello, namaste.
Namaste.
Yeah.
Can you hear me?
Yeah.
Yes, please go on.
Yes, namaste. I'm Bina Basnet. Exactly, sorry for the name. It is from my daughter's name, so I'm so sorry for that. I'm Bina Basnet, and I'm an emergency nurse working in emergency department of Tribhuvan University Teaching Hospital. Exactly, sir. I was asking this question which I recently mentioned in the chat box, because I felt this part of the emergency sector should be more focused, so that the mortality and morbidity would be minimized in the context of the Nepal, because most of the patient we receive in the emergency department, they just go to the private hospital by any of the medium they could afford from their side, and they again come to the hospital, just like government hospitals that they cannot afford due to the financial condition. I see most of the patient they are deprived of the service of the transport, either by the vehicle, because in our country we have many geographical issues we have to face, and so I think the governmental sector should be more sensitive towards this sector. So I mentioned that.
Okay, thank you so much, Bina, for putting the words that. So Professor Vaidya is there. He's
Yeah.
going to say something, sir. Please.
Yes. Just to answer the Bina's question. Yes, government is sensitive. They are trying, as Santosh said, like it's new thing for them. We have a guideline for EMS, pre-hospital care, already produced. We are using ambulance services for EMT trainings. We are doing dispatch trainings. Every province will have one dispatch center. Practically one number, like in West, we'll have 102 as one number for ambulances, which is already in process in Dhulikhel, Kathmandu, Pokhara places already. It's on the way. It's still early stages. And as for depending on the disaster funding is gone to local people instead of central. So depending on the local government, like in Kathmandu, 11 ambulances with EMTs with 102 dispatch centers are completely free. So in Kathmandu, if you call 102, you'll get completely free EMS anywhere in the place. The patient has the right to ask which hospital they want to go. Usually we provide them with the government hospital, but they would say, no, I want to go to a private hospital because they don't think government hospital may be crowded or something like that. So till they have the problem, I think till they have the choice, they will still choose private. Obviously, the funding, financing is a problem. Government is thinking of giving 24 hours trauma-free care for any hospitals in any hospitals. And also we have a insurance for people below poverty line, subsidized by the government, which now is will be including the emergency management also. Just to give you an overview of what government is doing. Thank you.
Okay, thank you, sir. Thank you, sir.
Professor Murray is there. Ma'am, would you like to put some more? You have yes, ma'am.
Sorry, thank you so much. Really
Yes,
wonderful to hear this discussion, and this commitment is just tremendous. I really think it is truly exciting. What I've just done is to put into the chat box the WHO Health Emergency and Disaster Risk Management Framework. And knowing that we have our WHO colleague in the room, I wonder if this might help you to engage with all the different sectors of society and all the different people who are the players in disaster and health emergency and disaster risk management to try and support this work. There's huge resources that sit inside WHO, but there's also huge research resources, which I've tried to share with you. And my privilege has been that I have obviously worked in the health domain in the UK for many years, but I'm also an associate fellow of our Royal College of Emergency Medicine and their global network. But I also have been working very closely with WHO to try and implement the Sendai framework. And I think the contribution of the Sendai framework response that I see inside the Nepalese health system is lovely. But shall we not encourage, it might be helpful to encourage the use of this new framework, which only came out in 2019. And I just think it might be helpful to all, because I just think that what you're talking about is what we're trying to address everywhere. Many thanks, and over.
Thank you, ma'am, so much. So anyone left, if I can't see your, before moving to another part.
Okay, just to mention a couple of things. Okay, so if you're really looking at the question came of nurses, emergency medicine, and about the things they can do. So one thing I can say is that the pre-hospital emergency care course of the Royal College, it has been designed that senior nurses can get those skills. And it will enhance and support the emergency departments where you have shortage of doctors and everything. So the pre-hospital emergency care, it doesn't mean you have to use it, some of the things like triaging, okay? You can train the nurses who are triaging. The other emergencies which we are there, we have actually called advanced nurse prescribers, okay? So field medicine, displaced people. The nurses can be used there as well, and so can the pharmacists be used. Immunization. Nurses can be trained to give immunization. You don't have to send doctors out. So there are several roles, but you build according to, say, okay, at time of emergency, we may need extra capacity. So whom can we train and actually and basic life support training. Okay, and all those skills are there around. All we need to do is just actually get them ready.
Yes, sir. So thank you, everyone. Still, we are on time now. I would like
Dr.
to
Ramesh,
welcome.
can I ask
Yes.
one question to
Please.
Samir
Please,
Adhikari?
Santosh.
I believe he is representing government. This is just relating to the questions from the nurses and other paramedic staff. The issue we face in emergency department is staffing at the moment. And I believe this is a global problem. The main reason for... Sorry, can you hear me?
Yes, please.
So the main issue is staffing and... Sorry, is there somebody else on the...
Yeah, continue. I'll mute it.
Okay, great, thanks.
Santosh, continue, please. Yeah.
Yeah. So the issue of staffing can be managed with motivation, but at some time, there is a limit of motivation that you can attract people. So there needs to be a proper recognition of their work and how it is remunerated. So what I'm asking is how the government from Nepal is putting extra resources and how they are remunerated. Because if you ask 10 nurses or 10 doctors what they want to be, the answers is rarely they want to work in emergency situation. They want to work in a more of elective situation. So and the disaster is always an emergency. So the question for the government of Nepal and the health sector, the MOHP, is to answer how you are going to motivate new generation to work in an emergency situation and work in a disaster situation.
Yeah, Santosh, you have a great message that you have mentioned. So I think we have time. I can go to our give a time to the Dr. Jukel Shrestha. He is now the final year DM emergency medicine resident. Dr. Jukel, are you there? So please put here some words.
Hello.
Yes, Jukel.
Hello, thank you everyone. Thank you international guests, thank you national guests, everyone. I'm a student of emergency medicine and also a disaster medicine. I'm totally interested in the subject. I'm the young aspirant, and now I can believe my seniors are doing well to make the pathway for the welfare of the patients. And we, the enthusiasts, the one who will be working for the people in the line of disaster, will have a better opportunity with this program, with this disaster medicine pavement being done today. Thank you so much.
Thank you, Dr. Jukel. Now I'll go to Dr. Robin Bum. He is also the DM emergency medicine resident. Dr. Robin, please. Yes, please go on, Robin.
Robin, we can't hear you.
Robin, we can hear you. You are unmuted. Yes. Now again unmute.
Something wrong with his okay. Robin, you can speak now. You're unmuted. No, I think you.
Yeah, some problem. I will go to Rojina. He is emergency medicine from Chitwan Medical College, UK. Now, Rojina, you come up for a few years. First, yes, welcome, Rosie.
Thank you, Ramesh sir. It was really a good session, especially, first of all, I would like to congratulate for the formation of the disaster medicine team in Nepal. The pioneer efforts are really appreciable. As Santosh sir told in the beginning, in the presentation, that the question is not if the question is when. So the key for the effective management of disasters and major incidences is preparedness, and forming a disaster medicine faculty would be definitely helpful in that.
Thank you, Rosina. Robin, back to you. Are you there? So, a problem. I will go quickly to the Ranjit Churashia. Ranjit, are you there? And you can put some words.
Hello. Hello.
Yes, Robin, please go on.
Hello.
Yes, Robin, please go on. Okay, I think some of the technical difficulties in the Robin's mic. Yes, we can hear you, Robin.
Hello.
Yes, please go on. Okay, now with due time, Professor Peter, shall I move to our members team now?
Please do.
Okay, thank you, sir. And thank you everyone joining all the panel discussion as well as question answer. Now I would like to invite our Nepal disaster medicine faculty members, faculty board to come to the dais to put your few words. Now, starting from Professor Dr. Deepak Datta, he's an orthopedician surgeon. He's a professor of orthopedics and trauma surgeon in the BU Hospital, NAMS. Welcome you, sir.
Thank you, Dr. Ramesh. Good afternoon, everybody. So, myself, Dr. Deepak Datta, working at National Trauma Center, which is a government level 1 trauma center in Kathmandu, a part of National Academy of Medical Sciences. And we have orthopedic residents, 9 orthopedic residents in a year, 27 in total. So we have been seeing a lot of disaster cases and have been managing disaster. But then able to manage disaster beforehand, or planning disaster management beforehand has been singularly lacking on our part. So to address that, we started sending out half of our residents outside Kathmandu at disaster points such as Dhari, Chitwan, Biratnagar, Sindhupalchok. But then we still think we have not been able to address this planning part. So when Dr. Ramesh invited us in this session, I was very excited because this disaster medicine involves not only disaster management, but planning before that also. So I think it will be very useful for our residents, for us as well, and for addressing the problem in our part of the world. And I hope the international faculty, sir, and our colleague, Dr. Santosh, is our colleague at, we studied in the same institution, and he was a colleague at Institute of Medicine. So we might be able to devise a plan, a course such that we are able to manage disaster, plan disaster before the disaster, before the patients come to hospital itself, address or save the lives in golden hour itself, which in Nepal, I think we're not able to address properly. So I think with all your expertise and all your decision, we'll be able to come out with a comprehensive plan. Thank you so much. Thank you, everybody.
To answer your question very quickly, with the help of Rob Russell, our expert from defense medicine, and Santosh, and 2 or 3 other people who will be able to actually support you in the orthopedic trauma prevention, preparation, or team building. And so this is part of one of the courses, but that module can be expanded to get people, much better trained. So, it is there in the modules, but I'll get you together with those teams to help you with that. And I hope you, along with other, your members of the team, will lead this area.
Thank you so much, sir. Thank you so much. Thank you so much, sir.
Thank you, Professor Datta. Now I would like to welcome Dr. Ashish Thapa. He is MD General Practice and Emergency Medicine. He is the head of Department of Emergency Medicine and General Practice in Armed Police Force. Welcome you, sir.
Namaste and good afternoon.
Thank you for kind introduction, Dr. Ramesh. My name is Dr. Ashish Thapa. I do work as a general practitioner and emergency physician at Nepal Armed Police Force Hospital. Great presentation. Thank you for such kind words. It feels great to be part of this organization. Looking forward to work with you and learn from you more in near future. Thank you, sir. Thank you. Namaste.
Dr. Thapa, just hello. Can you? Okay. Just a quick thing for Dr. Thapa and general practitioners. Professor James Kingsland, Nationalist of Primary Care, is our lead in strengthening primary care for disasters. Okay. Yes. So I will actually get him to work with you and other GP leads to actually develop and strengthen primary care in Nepal with a view of actually giving them extra, skills, or already those same skills developed to manage disasters in view of disaster medicine. So along with James, there are a few other people as well, but then James is going to be the main lead, and he's got 37 years of experience in this field. He's our government advisor, has been government advisor for many, many years. Okay, so we'll try and help you with that.
Thank you. That would be very great, sir. Thank you again.
Thank you so much, Dr. Ashish. Now I would like to welcome Dr. Sampurna Achapati. He is a PhD and MPH. He's a master in public health, and he has lots of research, all the data analysis, a lot of research he has been done. Welcome you, sir.
Okay. Thank you, Dr. Maharjan, for the nice introduction. Just I would like to introduce myself. I'm a data scientist and public health researcher. Like I have more than 10 years experience working in Nepal and abroad. So my training is on PhD in research methodology and postdoc in research methodology. And I have been working as one of the lead research organization in Nepal, and also helping and supporting the government and other police personnel for doing research in Nepal. So just I want to share some of my impression during this session. Like I want to share that Nepal is a high risk for disaster, as we know from 2015 earthquake and also from COVID pandemic. And the government of Nepal failed to cope with COVID pandemic during the second wave of COVID. So the major lesson learned during the COVID pandemic was to sterilization of public health system. So through this course, if we can train human resources, then it will help to sterilization of the public health system in Nepal, and that will also help to cope with possible disaster. So thank you so much, and I'm ready to work in this team. Thank you so much.
Thank you. And to support you, we have Dr. Jim O'Brien. He's, of course, Director of Wessex Public Health, and there are a few other people who actually are interested in public health. In relation to pandemics and epidemics, I'm a microbiologist and have been interested in infectious diseases. And along with the team, I've been working and supporting COVID. So once again, we have people with those modules, how to develop the role of public health and epidemiologist in disasters. So, but it's not about just pandemics and things like that. If you look at people who have going into refugee camps, displaced people living there for 3 to 6 months, it's not only the infectious diseases which you're going to worry about, but it's other health as well. So, it's to will enable people to think outside the comfort zone. And telemedicine, that's what we need, because the how to actually give healthcare to hard to reach people. And Nepal is a country where the terrain is so difficult. So how can we make use of telemedicine and technologies to support this healthcare? Perhaps you might have sort of thought about drones. What can drones do to support you? Okay, so there are technologies available, communication, but we'll work on that with you.
Okay. Thank you so much.
Thank you.
Okay, thank you so much, Dr. And now I would like to welcome Dr. Yagyalakshmi Sakhi. She is Associate Professor, Department of General Practice and Emergency Medicine. She is a coordinator of MD General Practice and Emergency Medicine. She has a He's lots of experience in the field of general practice and also the emergency medicine. Welcome you, ma'am.
Namaste, all of you. Okay, thank you very much for the wonderful introduction already. Dr. Ramesh has introduced me. I'm Dr. Yagi Lakshmi Sakya. Okay, working in the associate professor in the Department of General Practice and Emergency. First of all, I would like to congratulate our associate professor, Dr. Ramesh Kumar Maharjan, and coordinator, Dr. Rasmisa Maharjan. Okay, for organizing such a wonderful session, and best wishes for upcoming days and all like that. And I'm very much thankful for including me, one of the faculty member, for improving the quality care and all. As in the past like that, I've been working in the department for the last 16.5 years. So we have got some experience about earthquake and at present this COVID and all. So by establishing this ceremony, this program, that I would like to wish for by uniting all of us that to improve the best healthcare services in Nepal, and by uniting and by learning from each others. So thank you very much.
Thank you very much. And again, as I said, it's one of the things amazes me about Nepal. It's one of the few countries where GPs have actually done further courses on emergency medicine, and they're working in the sector of both emergency medicine and general practice. It's something which I haven't seen anywhere before, because we have only emergency medicine doctors, and occasionally few GPs actually do sessions in emergency medicine, but not as such large number. And same thing in India and other countries. So yours is a unique model, and we have a lot to learn from you. And we also have, but here is something which I'm going to throw at you. One of the major problems we have in many of the disaster displaced people are actually pregnant women. And they have emergency delivery, or they require emergency medical care and displaced. Now, that is something which has not been well developed in across many countries and many systems. So there's something you need, a particular program saying, if we're going to look at it, women's health, maternity, gynecological problems with displaced people, is it something we can develop some skills across your, emergency medicine and GP practices, GPs?
Yes, so I just want to share something like that. Here in our Nepal, that our MDGP program is such like that. We have got a 3 years program. So in the first year, we are trained like medical specialty, and second year is this, all the life-saving procedures like surgery and surgical specialty. And in the third year, like the last year, so in that is the emergency medicine. So we are trained like that, and also we have to go that outside valley and all like that, so that we have to care for because Nepal is such a poverty like that. So lots of obstetric problems are there in the out of valley. And so where the health facility is very, very, very poor. So our residents are trained like that. So we have to solve for the emergency life-saving procedures like obstetric emergencies and all the surgical things and all. So we are trying our best. So let's hope for the better. Thank you.
Thank you.
Thank you. Thank you so much, Dr. Yagi. Now I would like to ask Dr. Sweta Jaiswal. She's a surgeon. She's specifically for the plastic surgeon. So welcome, Dr. Sweta.
Good evening, everyone. I'm Sweta Jaiswal. I work as a reconstructive microsurgeon. I would like to congratulate my team for the inauguration, and I'm glad to be a part of this team and hope to work harder and better ahead. Thank you.
Thank you. And something I'm just going to say, I've covered most of the things, and one thing I've noticed in your team, which I have not been able to achieve in India, 50% of you are females, doctors who have volunteered to do this, which is great. Again, so I wish you all the best, and we will try and help you with all the support, mentoring, and access to resource. So welcome to the team.
Thank you.
you, Dr. Sweta. Now I would like to welcome Dr. Bist he is the anesthesia consultant and also assistant professor in the Tribhuvan University Institute of Medicine. He has a lot of research as well as he is the General Secretary of Society of Anesthesiologists. Please, that's easier, sir.
Thank you so much for including me. And I think we had a great time together, and I'm very happy that we have a lot of mentor, future everyone who can guide us. So in the meantime, I work in a tertiary level hospital in Kathmandu, TUTS, right? So is one of the biggest hospital, and we receive a lot of trauma patients. And my area of interest is in neuro anesthesia and neurocritical care. So I'm trying to seek a program on those specialty and try to contribute my institute on that line. So apart from that, as Dr. Maharjan has said, that I have a role for my society as well. So we're trying to develop some curriculum under our society in terms of subspecialty in neuroanesthesia. Hope collaborative work will definitely find some way, and we'll be able to do something for our country. Thank you so much.
Thank you very much. And later on, let's speak, after this meeting, and to see how we can develop your aspiration, your vision. I'm quite sure there are lots of ways we can do that.
Thank you so much. Thanks.
So thank you, Dr. Bist. I would like to welcome Dr. Rekha Staffit. She is the emergency physician consultant. Also, she is from the Manmohan Memorial Teaching Hospital. Welcome, ma'am.
Thank you, Dr. Ramesh, for the kind introduction. Namaste and greetings to everyone watching around the world. I'm Dr. Rekha Staffit. I'm working as a consultant in Manmohan Memorial Medical College and Teaching Hospital. Just recently, since the last 5 months. And I would like to give a big congratulation to Dr. Ramesh and the organizing team for taking such a great and courageous initiative. And I'd like to also thank him for the warm welcome and the great hospitality. Also, I'd like to thank our international faculty members and the board members for encouragement from all around the world, from countries all around the world. It's such a great privilege being a part of this team. It's a historic moment for all of us. And just hoping and looking forward to having great teamwork in days to come soon for the much needed development of disaster medicine in Nepal. Thank you so much.
Well, welcome to the team, Doctor. Great to see you. And let me again just very quickly introduce you to one of our very few female members, Dr. Arundhati Pawar, who spoke early on. And she is an inspiration to people in India. She actually has her own WhatsApp group and actually encourages people to look at medical healthcare. So yes, I will look forward to actually working you, and you're welcome to the Nepal leadership team.
Thank you so much, sir.
Thank you, Dr. Rekha. Now I would like to welcome Dharmalakshmi Shrestha. She is a very much respected emergency nurse, and she has a lot of experience of her career in nursing. And she is the nursing director of Tribhuvan University Teaching Hospital. Now she is a nursing administrator, the highest post in the Nepal. And she is also the president of Emergency Nurses Society of Emergency Nurses of Nepal. Welcome you, ma'am.
Thank you, Dr. Ramesh. I'm Dharmalakshmi Shrestha, nursing administrator and the president of Society of Emergency Nursing of Nepal. Thank you very much for organizing this valuable program, and thank you for providing me to say a few words for this program. Nurses are also the valuable team in the management of disaster and emergency management. We, the nurses of TU Teaching Hospital, have prepared the 3-month emergency nursing care training program and have produced 2 batches of nurses from TUTS and the other hospitals of Nepal. The package will support the immediate nursing management of disaster as well as emergency nursing situation. So we had also organized a Society of Emergency Nurses of Nepal, SEN, for supporting and enhancing the efficient nursing care in emergency nursing care service in Nepal. So thank you, Dr. Ramesh and organizing team in inviting in this program. And I wish the nurses will be given priority in involving every part of disaster and emergency management activities. Thank you.
Thank you very much. It's great to see nurses involved in this program. And I must say the nurses are backbone of the healthcare. Without nurses, we cannot, no doctor, no public health can actually move forward. They are actually integral part of the team. So welcome team. And I'm going to actually throw one area at you. You're looking at nurses, emergency nursing service, everything. Now think about how can we develop nurses' skill for out of hospital care? Not necessarily emergencies, but out of hospital care, or hard to reach people, displaced people, because we do not always have sufficient number of doctors to go out and do that. And there's a lot of care out there which can be actually managed by nurses. So there is something there which you might want to think about in developing the skills for nurses.
Yes, I'm also nursing in service education coordinator also in teaching hospital. We are providing refresher courses for the different type of the subjects in the teaching hospital nursing staffs. So I think it will be also support in the care of the patients in the emergency situation as well as in other situations. Thank you. Thank you, sir.
Thank you, ma'am, for your such a great work in Nepal from the nursing team. Now I would like to welcome Mr. Ekdev Nepani Ramesh. He is an EMT. He is really great paramedics who flies Delhi. And he has been experienced a lot of work from the road, from remote part of the country. Now he's working in the Medicity as an EMT. Main person from the back one. Please, stage is yours, sir.
Sir, thank you, Dr. Ramesh, for beautiful introduction. I would like to thank Dr. Ramesh Maharjan and Dr. Pradeep Vaidya for taking initiation to establish disaster medicine in Nepal. And also, I would like to thank Dr. Patel for supporting us. And I would like to thanks for such a wonderful program for everyone. And also, I want to say pre-hospital care is one of the most important part in disaster. So we have to develop a lots of paramedics and pre-hospital care nurse in Nepal. Thank you very much.
Thank you. And as I said in my talk, we are working with the pre-hospital care, emergency care faculty of the Royal College of Surgeons of Edinburgh. And yes, we have a course here which they examine, people qualify. But now it's been agreed that the Western courses are not always suitable for developing countries because of the resources and limitations of challenges over there. So they are now actually working on an international course, examinable and certifiable by the Royal College, which will actually give skills for those doctors working in Africa, India, and those kind of countries. And it will be equally useful for people to develop those skills. So glad to know you're interested in that. And if you're interested in joining that pre-hospital emergency care faculty, I would like to invite you, and I'll introduce you to Dr. David Bruce and Rob Russell, who are actually leading on this.
Thank you, sir. Thank you very much. Thank you so much, our EMT, for the pre-hospital care service, and that is the going on from the various organizations. Now the initiative from the Ministry of Health, National Health Training Center on the first batch training from the government side as to make all over the Nepal. So this is one of the most important part of the disaster medicine as well. Now, with the time permission, I would like to welcome Mr. Pradhan from the Times Pharmaceutical. You put some words, sir, please.
Thank you, Dr. Ramesh. Thank you for giving us the opportunity to be associated with the disaster medicine that is going to start in Nepal. Nepal is actually, it is a topography of the Nepal is very unique. So we have been facing a lot of disaster from earthquake to flood and so many other things. We will be happy to introduce our different medicines, and this disaster medicine will also help our pharma industry to grow in a different way. As Nepal is also growing slowly in a pharma industry, we have been starting our different units. We are also going on a sterile projects. So development of the medicine also equally associated with the disaster management of Nepal. We would like to support in coming days equally. So I would like to once again thank you for DrRamesh and the society. Thank you.
Thank you very much and welcome to the team, and look forward to working with you.
Thank you, sir. Thank you.
So thank you so much, everyone. Now, with time due, if any remaining, Professor Peter, Dr. Santosh, and everyone. Otherwise, I would like to welcome Dr. Rasmisa for Thanksgiving vote of thanks at the end. So before that, I request Professor Peter some words, please.
All I would like to say is congratulations on this innovative and very, very important launch. Welcome to the team. And I would actually also like to invite Professor Virginia Murray to actually add some closing remarks to this, and then it's over to you. And thank you very much for inviting all of us. We look forward to working with you.
Yeah.
Wow, Peter, what a privilege. What an incredible, huge engagement. I am so excited to be working with you all that I've been putting far too much in the chat box. Apologies. But I just feel that your commitment and enthusiasm to do this, which is so vital, I believe, and to have Nepal as such a leader in this by setting up your very powerful faculty will be such a privilege to work with you. And I have delighted in the whole of the work that you've been sharing and that incredible engagement. I can't thank you enough for including me, and I just look forward to doing much, much more with you over the next while. Peter, thank you so much for including me as one of your advisors from the international point of view. But wow, I just wanted to go thank you, all of you, and it's just amazing. Congratulations. And I hope the faculty goes so well, and remember that we're here to help.
Thank you.
Yeah. Thank you, ma'am. Anything left before we move? Professor Peter.
No, it's over to you. Oh, I'm
Okay,
very quickly just to thank my Indian team. They are still out there talking, so thanks to them, and thanks to my international team. And all I can say is this will be a great partnership in South Asia.
Thanks, sir. Before that, any our colleagues or friends from Sri Lanka? Are there?
I don't think Sri Lanka people could make it. I can't see them there. Or they...
Okay then, sir. Santosh, would you anything remaining before we going to close?
It was a wonderful program, Dr. Ramesh, and very, very impressed by the enthusiasm in your faculty. Thank you very much, Dr. Ramesh, for organizing this.
Okay, then thank you, sir. So with your permission, Professor Vaidya, Chairman,
Yes.
So I will, yes, sir.
Yeah. Really wonderful. As I mentioned previously, it's a historical day. And thank you very much, Professor Peter. It's been a long time due that we started. And probably because of COVID or despite of COVID, we were able to do it. I'm very glad. And thank you to the international team and Santosh. Thank you very much from Santosh Pradhan. And obviously, having all this said and done, the most hardworking person is DrRamesh Maharjan and his team, who have made it such a successful thing. So hats up to you, and we will move on from there, coordinating with all the team members, all the international and national teams to make it a successful process that will continue for long. Thank you very much, and see you. Have a nice day.
Thank you. Thank you. With your permission from the chairman and international director, Professor Peter, now I would like to request the coordinator of NADM Center, Dr. Rasmisa, to give the vote of thanks.
Namaste. I'm Dr. Rasmisa Maharjan. I'm currently working as a house officer in Manmohan Cardiothoracic Vascular and Transplant Center. And as a coordinator, it's been a privilege to work with you all. And it's so I suppose I'm the youngest one member in the board. And I'm very happy and looking forward to work with you all, with our great team. And I would like to give a vote of thanks to Professor Dr. Peter Patel, International Director, Disaster Medicine, Professor Dr. Pradeep Vaidya, Chairman, Nepal Disaster Medicine Faculty Board, and Dr. Samir Adhikari, Chief Health Emergency Operations Center, HEOC, Ministry of Health and Population, Government of Nepal, Professor James Kingsland, International Guest Speaker, Professor Murray, International Guest Speaker, Dr. Santosh Pradhan, Member of International Advisory Board of Disaster Medicine, Dr. David Bruce, Pre-Hospital Care Faculty of Royal College of Surgeons, Dr. Nobindraj Vista, member of our team, Mr. Bimal Singh Bist, Health Emergency International Officer, WHO, Kathmandu, Nepal. And also I would like to thank Dr. Ramesh Kumar Maharjan, our Chief Coordinator, and all the participants physically and virtually from India, Sri Lanka, Europe, and everyone. And I would like to also thank Saving Life National Association of Primary Care, Times Pharmaceuticals, and lastly, M Family Hospitality for such a wonderful team and for the program. Thank you.
So at last, I must thank you, Ian Wren, our Parazuli, who has made the success to do this meeting, the establishment of disaster medicine in Nepal. So from Nepal Research, so I would like to before closing the Zoom, he is the master, Mr. Nirajan, please. Please, with your few words and closing the Zoom.
Thank you very much, sir, for a very wonderful program. This is a very big event. So we'll continue support, and then we'll continue support for this kind of program. Thank you. Thank you, everyone. Thank you very much.
Okay. Thank you.
Thank you
now,
very much.
Yes. Okay. Thank you, everyone. Namaste to everyone.
Bye-bye, all.
Okay.
Thank you.
Okay.
Thank you, everyone. Bye-bye.
Bye-bye.